So first, I'd just like to welcome everyone to this training webinar, and thank you all for coming, especially given it's a Friday evening. So this is the first of two sessions being held tonight and next Friday, the 26th of November, on axillary node marking. So to begin with introductions, my name is Sophie Cramp. I'm the trial manager for ATNEC based at the University of Warwick. And I'm joined on the call by my colleague Natalie Hammonds, who is the trial coordinator for ATNEC as well. The session's been moderated this evening by two members of the ATNEC trial management group. So we have on the call Mr. Amit Goyal and Miss Beatrix Alsberger. Amit is an associate professor and consultant oncoplastic breast surgeon at Royal Derby Hospital, and Amit's also the chief investigator for the ATNEC trial. And Beatrix Alsberger is a consultant breast surgeon also, who's been based at Aberdeen Royal Infirmary since 2018. Beatrix has an interest in clinical academia and translational breast cancer research, and is also a co-investigator on the ATNEC trial. So as you'll know, these training webinars are being hosted by the ATNEC trial, which I know is a study that is already open or set up in many of your centres. So I'd just like to thank you for your support of the study so far. If ATNEC isn't yet open at your centre and you would be interested in participating in the study, we are still accepting new sites. So please just get in touch via the email address that's on the screen there if you are interested in opening the study. So just to give you an overview of this evening's schedule, so we have three talks planned for this evening. The first will be from Mr. Henry Cain, covering radioactive iodine seeds and the Maori procedure. And then Dr. Shama Puri will give a talk on node marking using black dye tattooing and clips and coils. And then finally, we'll have a talk from Mr. Peter Barry on the use of Magseed for marking the involved node.
Okay, well, thank you very much for the introduction, and thank you for the invitation to speak this evening. I'm going to relatively swift run through what we've been doing up in Newcastle really since 2015, when we introduced the concept of a targeted axillary dissection and the technique that we initially adopted, which is using a radioactive iodine seed. These are my disclosures, and I think if you go down the list there's no one involved with sticking any clip seeds or anything in armpits or chopping them out, so I don't actually have any conflicts of interest with regards to talking about targeted dissection. So very briefly, I'm going to run over where and why did we start, what were we faced with right at the beginning of this back in 2015, why we use an iodine seed in a targeted dissection, what's really been the impact of what we've done up in Newcastle, and where we're looking at heading to next. And so I think there was any questions in the chat box, and hopefully I'll sort of pick things up at the end there. So why and where did we start? So back in 2015, we were really driving the use of neoadjuvant chemotherapy, especially in our triple negative cancers. Targeted anti-HER2 therapy was yielding really high rates of breast and axillary PCR. And we relatively quickly adopted changing our plan with regards to breast surgery and downstaging the breast. But it became apparent that we were seeing significant downstaging of the axilla. And it gets a bit tiresome doing axillary clearances on people who've got complete pathological response, and so that was probably the start of the driving factors. Actually, looking at if we're going to change our plan in the breast, we probably ought to be changing our plan in the axilla as well. The concerns of the pushback that we were getting at the time was predominantly from some of our clinical oncology colleagues, and that was with regards to the accuracy of a standard sentinel node biopsy for patients who are N1 pre-neoadjuvant chemo. In some units, it was a challenge even to get the acceptance of a sentinel node biopsy following patients who were N0 at the beginning of neoadjuvant chemotherapy. We managed to get over that hurdle relatively quickly, and our standard practice was a post-treatment sentinel node biopsy for those patients. But in the N1 patients, that was the sort of the pushback we were getting was from that false negative rate. At the same time, in sort of 2013, up in Newcastle, we had actually switched from using guide wires to using iodine seeds for our breast conservation surgery. And that was based upon evidence from the US. And we spent a bit of time over at the Netherlands Cancer Institute, where they'd introduced iodine seed localization back sort of 2010. And so by 2015, we'd adopted that. We're up and running. We've probably done about 250 cases, and we've published our first results with regards to using that technique for localization of breast tumors rather than using guide wires. So the question about the false negative rate kept being sort of thrown back at us, and what was the sort of concern there? Well, we had this the Centina study, which demonstrated a false negative rate of up to about 15% if you did a standard sentinel node biopsy in a patient who was N1 pre-treatment following their neoadjuvant chemotherapy. So you're going to be missing some residual disease in the axilla. There was then some great work that came from Abigail Cordell and Henry Kerr at MD Anderson, looking at, okay, what steps can you take to reduce this false negative rate? And certainly, you know, they demonstrate that taking 3 or more nodes would reduce your false negative rate to 7.5%. If you marked the pre-treated node and then targeted that clipped node alone, you'd reduce it to 4.5%. If you combined this idea of targeting a clipped node, taking the clipped node out, and also using a dual technique sentinel node biopsy, then you're getting a false negative rate of below 2%. And we have to accept that, you know, the standard false negative rate of an upfront sentinel node biopsy is very much dependent on the number of nodes you take, but it can be as high as 12%. So these sort of numbers there, just, you know, it gives you the confidence that you're not going to be missing much disease left in the axilla. And that was really the concept of the targeted axillary dissection, which was using the combination of a pre-treatment clipped or marked node and then taking that clipped node out along with a dual technique sentinel node biopsy. And that's the sort of direction that we decided to head in back in 2015 in Newcastle. So the position we were in, we had a clinical problem of high false negative rates with the standard sentinel node biopsy. We'd got some robust techniques using iodine seeds. That was the first technique that they introduced in the MD Anderson there. And then the Netherlands Cancer Institute quickly published their work on what they called a Mari node, significantly reducing the false negative rate. And we'd established an iodine seed service in our unit for the breast conservation surgery. So it was really a logical step that that's what we were going to use to target our axillary nodes. I'll take this opportunity just to briefly talk about the Mari node procedure, because that is slightly different to what we're doing at Newcastle and certainly what the majority of units in the UK are doing. They introduced this probably about sort of 2012 back in the Netherlands Cancer Institute. And the concept of this is using the radioactive iodine seed to mark one single lymph node down at the bottom of the axilla, really irrespective of axillary burden. They then monitor response using PET-CT, and then at the end of treatment, they then target that single node. And so this is the sort of group where you're taking a single clipped node out and using that as an indication of axillary response. And this is the sort of this is a sort of schema that they've drawn up for this. So you've got patients with FNA positive axillary lymph nodes. They then do a CT PET before they start, and they divide them into 2 groups. Basically, your N1 group and your N2 group. So 1 to 3 nodes and more than 4 nodes. And then they clip that lowest, most abnormal node. And it's really interesting to sit in their MDT and watch them, because they'll do sequential CT PET scans, which are a luxury that they have over there. And they'll do them after each course in the research program, and you can see the nodes switching off. And they do actually appear to switch off from the apex down. And then they do their surgery there, where they'll target that one single node. They think they've got a false negative rate of well below 5% by just targeting that single node, based on the theory that if the bottom node has got a PCR in it, then the likelihood of having further disease up the axillary train is very, very low. They then look at what they get at the end of treatment, and so they have groups which have got PCR and groups with residual tumor, and then depending on the initial nodal burden, they then decide what further axillary treatment they give. And so if you've got a low burden axilla with a PCR, they don't give any further axillary treatment. If you've got a low burden axillary with residual disease, they give radiotherapy, and they work through like that. High burden disease with a PCR auxiliary radiotherapy, high burden disease with residual disease, they then go on to a clearance. And they've published data where if you follow these patients through, so a group of 160 patients, and if you work through depending on axillary burden, pathological response of the Mari node procedure, and then what treatment they actually end up with, it appears that about a quarter of patients will end up with no further axillary treatment, and only 18% of these patients actually end up with a formal axillary clearance and radiotherapy. And they're now looking at publishing sort of 5-year recurrence rates on this, which are certainly acceptable, if not better than anything else we'd see with standard treatment. They are very careful about the biology, and they're really only doing this in patients with chemosensitive disease, which are triple negative or HER2 positive cancers. As I say, we sort of moved away from that because we actually preferred the technique where we were going to use the localization of the node in combination with a dual technique. So to move back now to what is a radioactive seed. A radioactive seed is a small sort of 4mm pellet. It's got a titanium capsule. It's got a gold marker in the middle of it, so you can see it very easy on mammograms. And it's got a radioactive iodine isotope contained within it. As I say, we introduced this for localizing breast tumours, and we've localized over 2,000 breast tumours using an iodine seed now in Newcastle. You use your standard gamma probe that you'd use for a sentinel node biopsy. Most modern, if you've bought a gamma probe in the last sort of 5 years, it will have different isotope options on it. And iodine 125 will be one of those isotope options. So you can just toggle between your technetium and your iodine 125. So you don't need any different kit. So what's the challenges of this? Well, it's all around satisfying the radiation protection offer and the RSAC license certificate. Because it's a contained source of radiation, you need to be able to account for where that seed is at all time. And so the seeds need to be registered when they enter into the breast unit. They need to be registered which patient they're in. And then when you remove the seed, they then need to be returned to the breast unit for disposal. And you need some way of tracking that seed all the way through its journey. After doing over sort of 2,000 of these, we've had no problems with seeds going AWOL, and we've been in a situation where patients have had seeds put in the breast, and then they've had medical incidents, which means they then don't end up having surgery. That's absolutely fine because you know where the seed is. We've had patients who have passed away after having localization there, and that's absolutely fine because you know where the seed is. And so we're in a unit which have a very active on-site nuclear medicine department, and so we've had no real problems with entering this. This is a challenge when you don't have an on-site nuclear medicine department. So this is not the fix. Certainly, this is not the fix for the majority of units. It just happens that we had it up and running in here before we started targeting nodes. So what was the advantages for us? Well, it was very, very familiar. It's a technique that we're doing all the time on a daily basis. It's very familiar in theatres, and we've got the protocols that allow us to use it. We only need one probe, and so you're not chopping and changing between your technetium probe and then reaching for anything else. It just is a single toggle on a switch. We don't need any alternative instruments needed. This is actually cheap, and so we're now paying around 70 to 80 pounds for the iodine seed with the delivery needle and with the delivery system there, which, yes, it's about double the price of your guide wire, but it's actually relatively good value. And we're localizing 300-400 of these a year, so the cost of it is an impact for our unit. We quite like it because it's MRI compatible, and so you can stick these in the breast and then you can re-MRI the breast if you need to. We will pre-localize all our positive lymph nodes now at the pre-treatment, and so they'll be in there for 6 months. So we will be MRIing the breast for response, and so we need something which is MRI compatible. And that's the idea of this sort of fire and forget. So right at the start of the patient journey, when we've got a biopsy or an FNA positive lymph node, the next step is to put one of the seeds in it, and then it just sits there, and it will sit there for the 5-6 months worth of treatment, and then it's there when you need it at the end of treatment. They're very visible. They're clear to see on MRI scan. You don't get any scatter. You don't get any artifact or anything like that. Our radiologists appear to love them, and so we've sort of carried on using an iodine seed. I'll just move on to sort of talk to you about the introduction in Newcastle and our sort of experience. We sort of published some initial results back in 2019 and then updated some over the last year. Our sort of pathway for these patients is that we really select them based on biology and axillary burden initially. So we're only looking at using axillary downstaging techniques in patients who are chemosensitive, so your triple negatives, your HER2 positives. There are very few patients who are ER positive, HER2 negatives that will actually go down this pathway, and I'll explain a bit when we've reviewed some of our results why that is. We initially started pre-marking these with an ultrasound clip. We were using a 2-mark clip because actually that's the easiest one to see 5 months down the line. Some of the other hydromark clips are pretty tricky to spot after the patients have had their chemotherapy. As soon as we sort of adjusted our license to be able to put these in for 6 months, we switched relatively quickly to putting them in with an iodine seed, because it can be quite tricky. So the radiologists tell me to see a clip which has been in a node after 5 months worth of treatment if that node is scarred up and things. So that was our sort of initial experience, was going through various clips. The 2-mark clip was the clip that they were using over in MD Anderson, and so that's what we adopted. And the 2-mark thing is it goes in like this, and then it expands up, and so the radiologists tell me that that's relatively easy to see with an ultrasound machine after 5 or 6 months. We then obviously complete the neoadjuvant chemotherapy. We do look at the response, and especially the breast response. And so sometimes it's difficult to judge an axillary response on MR plus ultrasound scan there. But actually, we go along the lines that if we see a good breast response, and then would certainly proceed with a targeted axillary dissection, expecting a good response in the axilla. And actually, when we've looked at our combined results of PCR in the breast and PCR in the axilla, we didn't actually have any patients in a series of over 250 where the patient had had a PCR in the breast but failed to have a PCR in the axilla. We had quite a few patients the other way around, which had got a complete response in the axilla but failed to develop a PCR in the breast, but we had no patients that were in the other direction there. So I think your breast response gives you a really good steer about what's going on underneath the armpit. We then proceed with the iodine seed excision of the marked node and combine that with a dual technique sentinel node biopsy. We've now actually switched on the majority of our patients to ICG rather than blue dye. So they get the technetium injection on the ward. They then come down to theatre, and we'll give a ICG injection on the table, and then actually use that as the combination with technetium to identify the sort of next level nodes. At the moment, and certainly until we've adopted ATNEC, all our patients were being offered further axillary treatment following the targeted dissection, and that would usually be radiotherapy if they'd not had a clearance, and radiotherapy if they'd had a PCR, and if they had residual disease, especially macroscopic residual disease, they would be going back for an axillary node clearance. This was the very first case that I actually did back in 2014, end of 2014, and that was using a guide wire because we were just sort of trying this out there. So this is a patient who have opened up the axilla. We see a guide wire going into a node. That node has picked up some blue dye, and then you can see the sort of second level nodes above it, and that's what the specimen X-ray is looking like. So very early on, we're using the Hydromark clips and a guide wire in. Using a guide wire is really difficult. They don't seem, irrespective of what wire we use, we tried 2 different wires, they just don't stick as well in lymph nodes as they do in the breast. It's obviously different tissue you're putting it in, and it was incredibly easy to displace the wire. And so we probably did about sort of 5 or 6 of these, and got bored of them relatively quickly because the wires just don't lock into the lymph nodes like they'd lock into a bit of breast tissue, and so it's a bit tricky. And anyone that can get this working for them, I think, is probably got a more surgical finesse than I obviously have. This is what things look like when we switch to the 2-mark clip. And so this is a 2-mark clip in a node there and an iodine seed placed in the same node. And we tend to take these as an en-bloc resection. And so we go in, we identify where the lymph node is with the iodine seed. We then open that sort of the clavipectoral fascia above it, and you'll see your blue dye or your ICG coming down there. And then we'll just reflect a sort of en-bloc resection there, and usually ending up, so our average yield is 4 nodes in these patients. So what was our initial impact of introducing a targeted dissection in neoadjuvant patients? Well, we looked at the first 35 patients. So these were N1 undergoing neoadjuvant chemotherapy. We had about a sort of 70% PCR rate, which was in keeping with what we'd seen beforehand there. And in these patients there, these were patients who had evidence of regression and scarring, but no viable cancers in the clipped node. And the vast majority, so all of the patients had evidence of regression and scarring in the clipped node, so the marked node, and then some would also have residual scarring in the sentinel node sitting above that node. Because initially we were doing this strictly in patients that we had low volume disease, so these were all the N1 patients. The remaining 10 had residual tumour in one node only, and that residual tumour as part of the targeted dissection was in the marked node. We didn't have any cases where the marked node had a PCR and we had residual tumour above it. it's interesting, when we're doing the technique, it was not infrequent that the node that we were identifying with the I-125, when you toggled across to technetium-99, that wasn't the hot node, and so that would be a technetium-99 cold node, and the technetium hot nodes would be the sort of the next echelon of nodes up, and that was happening in about sort of at least a third, if not half cases. And that's, I think, where we're obviously seeing the false negative rate in using technetium-99 alone. And you were seeing these nodes which were scarred up after treatment. They weren't getting hot on the technetium, and that's why they were being missed in those initial studies there. We didn't have any patients where the targeted dissection failed to identify a node with associated response there. We actually took 3 of these, so 7 of the patients with the residual disease only had isolated tumor cells left there. So we accepted those, and we gave those patients radiotherapy. In the patients with macroscopic disease there, we took them back for a clearance, and only in one of those patients did we find any further disease sort of higher up the axillary chain, and that was someone who had a very poor response to their neoadjuvant chemotherapy. And so we could see a significant reduction in the number of patients undergoing a completion clearance. So where are we now, and what are we doing now? We've sort of had this established really since sort of 2015, 2016 now, and we now offer it to all our N1, and over the last sort of 12 months begin to offering it to N2 heavier burden patients there. We tend to limit it to HER2 positive or triple negative patients undergoing neoadjuvant chemo, and we've now done over 70 neoadjuvant targeted dissections. We have been using it over the last couple of years with regards to patients who are going for upfront surgery, who we know on their pre-op staging have a positive lymph node, and we want to target that lymph node as part of their sentinel node in upfront surgery. And then we were putting those patients into the POSNOC study after the amendment, which allowed us to target those lymph nodes and putting them into the POSNOC. The reason why we were targeting the lymph node there is we did have a couple where we'd get a pre-op positive staging, we'd do a sentinel node biopsy, and you'd miss the node with the cancer in it, or you wouldn't be confident there. So we started targeting all those as well. We've gone back and we've looked at our auxiliary response to neoadjuvant chemotherapy, and even though we're very selective over what positive HER2 negative patients we give chemo up front to, so we tend to give it to high grade tumors, sort of poor, sort of your 5 out of 8s, 4 out of 8s, PR negatives, and even being relatively selective over who we give up front chemo to, we're still only getting a PCR rate, but just below 15% in the axilla. And so that's why we don't tend to offer patients who have got positive HER2 negative disease an axillary downstaging sort of pathway, because you know that sort of 9 times out of 10 you're going to be going back there and doing a clearance because you won't sterilize the axillary in these patients. We're sort of, as I've already said, we routinely offer radiotherapy to these patients, but now we've got ATNEC open. We've actually got our first patient just being registered who will go into ATNEC, and obviously they'll be randomized to either axillary. They've had a PCR in their axilla, and they'll have the randomization either into axillary treatment or observation. Where will we go next? Will we always use iodine seeds? Probably not. We will switch our technique when we switch our breast localization technique, and we've looked at the various options of Magseed, the radar deflector, the RF tags, and at the moment, because we've got a relatively slick pathway, it's very straightforward. We've done over 2,000 of them. It's predominantly a sort of a cost issue that a lot of it's coming down to, and a kit issue. And at the moment, we're not quite ready to jump ship with regards to our breast localizations. As soon as we actually change our technique of breast localizations, we'll change our technique of targeted dissection, because the radiation side of things, it's another hoop to jump through. It's another form to fill in while you're doing your operation and things like that. And it'll be nice not to have to do that. The concept is, and sort of my take on it is, it doesn't matter what you're using to target the node, so long as it works effectively for you, so long as it's economically sensible to do. Anything's better than nothing. And so we will probably change at some point in the future. We're adopting more use of ICG sentinel node biopsy. So certainly in our patients where we'd usually be using blue dye as part of a dual technique, we're switching out the blue dye for ICG. And as we're getting more familiar with using ICG, there's some good evidence coming through now that actually that's probably as sensitive as technetium alone as a technique. And so if you're going to, if we move away from using radiation with regards to localization of tumors, we may well move away from using radiation with regards to our sentinel nodes and go purely for an ICG type sentinel node. We're in the process of looking at some of our results of that, and there's a couple of studies coming through which might be interested. I know Cambridge are running some studies looking at ICG in the axilla. The other thing is identifying patients who don't require any sort of surgical staging of the axilla, and I think there's some good evidence now that if you've got patients with an N0 pre-neoadjuvant staging who've got chemosensitive disease, the likelihood of doing a sentinel node biopsy in those patients and finding residual disease is incredibly low. And so I think we'll see some studies coming through now which are going to identify the fact that actually there's a group of N0 chemosensitive patients that probably don't need any form of surgical staging of their axilla. And I think that's about where I've got to with it. So I will come off here and stop sharing my screen. And I think that's about it, Amit.
Thank you very much, Andre. Thanks a lot. So I'll just open this to discussion. If there are any questions, you can put them in the chat box or raise your hand. While other people, I'm just waiting for other people to ask a question. Andre, can I ask you a question, please? Is there a signal decay with time for the iodine seed, that you leave it for 5 to 6 months? There
is, Amit, but the half-life of iodine 125 is quite long, so 60 odd days there. We actually put a lower strength, so our standard seed going in the breast will be about a 7 megabecquerel seed that goes in the breast there, and that's just because irrespective of how deep in the breast it is, you're going to get a great signal to be able to localize your tumor. For the patients which are having them in the axilla, we actually use a lower strength seed. So we usually use about between a 3 and a 4 megabecquerel seed. So we use a pre-decayed seed, basically because you're going to be straight on top of the node anyway. You don't need that strong a signal. And that's based on the work done on the Mari node. They use a pre-decayed seed. And certainly you can put that seed in and 6 months later, you still get a great signal that you're going to be able to take that out. And you'll get similar counts from the iodine seed as you will from your sentinel node technetium 99.
That's useful. And I thought you mentioned about a retained seed, and that there have been cases where there was a retained seed in patients. I'm just wondering, from a radiology point of view, is it possible to take them out using vacuum biopsy?
You could do, but we've never. We've never had to, because with regards to the breast, they only get localized usually between sort of 7 days and 2 days preoperatively. So you're fairly committed to the operation there. We had one patient who had their breast localized and then unfortunately had a massive MI 2 days pre-op and died. So that was slightly awkward. I was glad it happened sort of 2 days pre-op as opposed to 2 days post-op. And that there, so long as it was tracked as to where she was, and that patient ended up being cremated, then that was absolutely fine. You've got to remember that these are exactly the same seeds used in prostate brachytherapy, and so there are people being buried. There are blokes being buried and cremated all the time with these seeds in the body. So so long as we can turn around when we get an RSAC inspection and account for where every one of these seeds is, then that's all that sort of mattered.
Thanks, Andrew. One more, if you don't mind. Just, I think, if anyone listening, and even, because we'll be circulating the presentation to various people, so if someone would like to adopt this, is there so the iodine seed for the supply chain, do they have to contact the nuclear medicine department for that to set it up, or?
Yeah, absolutely. You need this running through. You need this running through your nuclear medicine department, and that's what we've had great support with. We've got the RPO there is absolutely been a supporter of this since back in 2013. Personally, unless you're using these for localizing your breast disease, I wouldn't set this up just to localize your axilla. I think over the next few presentations you're going to see that there's far more straightforward ways of localizing the axilla rather than putting a seed in it. The concept is exactly the same. We just had this technique up and running for it, and so it was the next logical thing for us to do. Rather than go down the line and investing in a load of new kit and just to do the axillas, we just adopted this technique for it. So I think that, you know, I think there's only sort of 3-4 units in the UK using iodine seeds. For them, if it's working very well, yeah, bang them in the axilla and use them for your targeted dissection. Personally, you know, if you don't want to find yourself in the situation where you're using guide wires in the breast and using these in the armpit. It would be completely illogical when you've got these other options. And so that would be my sort of take on it. Whatever you're doing, it's better than just girdling on with a guide wire.
Thank you very much, Henry. I'll invite Dr. Shama Puri, who is the clinical director for screening and consultant radiologist at the University Hospitals of Derby and Burton, to talk regarding marking the node using black dye and clips.
So I'm going to speak about black dye tattooing and marker clips because that's what we use in Derby and Burton for marking our axillary nodes. So black dye is basically a sterile carbon suspension. And the concept of using black dye into the axillary lymph nodes came from the fact that it's commonly used to stain tumors during endoscopy. And also some centers in US and Europe are already using it to mark their nodes and breast lesions. Now, in preparation for ATNEC trial, we decided to do a feasibility study to see if this concept will work for axillary nodes in patients with breast cancer. So the main aim for this study was to determine if the axillary nodes can be marked using carbon dye and also if they could be successfully retrieved at the time of surgery. We also looked at concordance between the tattooed node and the sentinel node. So the study included 110 breast cancer patients with positive axillary nodes. All these patients had carbon dye injected. We used spot in the beginning, and that comes as 5 ml syringes. And later on, we moved on to black eye, which is 1 ml packaging. All the patients had either primary surgery or they had neoadjuvant chemotherapy followed by axillary surgery as per their routine care. So the key results from this study was that tattooed node was identified intraoperatively in 82% of patients. And also the tattooed node was the sentinel node in 80% of patients. We also noted that identification rate of the node did not vary with timing between the injection and the surgery, with the volume of dye injected or with BMI of the patient. And there was really no learning curve for the radiologist or the surgeon. However, we did optimize the technique as we went along. In the beginning, we were using far too much of dye and we were injecting at various sites, including perinodal tissue and along the tract. But as we did more patients and they were operated upon, we realized that you really don't need that much of dye to stain the node. We require only minimal amounts. If you put too much, it just gets into the perinodal tissues. We also did some in vitro experimentation by injecting dye into the lymph nodes, which were removed from the patient, and realized that all you need is minute amount of dye. And if you inject more, it just seeps out. So after all this experimentation, we found that the most optimal volume was 0.2 to 0.4 mils. So that's really a small amount. And that's why we moved from spot to black eye, because black eye is available in 1 mil packaging rather than 5 mil. You inject into the cortex of the node, and there is no need to inject around the node or in the tract. And this injection can be done at the time of the biopsy if radiologist is confident that the node is malignant, or it could be done on a separate visit. So I'm going to show you two videos. One of them, the first one is ultrasound video showing how the black dye is injected, and the second one is the surgical video when the black node is retrieved. So I'm just going to load the video. So patient is positioned with arm raised. We identify the abnormal lymph node. And then the dressing pack has got local anesthetic, and that's the black dye. It's in 1 ml syringe. And I've discarded most of it, just 0.4 ml is left. So here we are giving local anesthetic into the skin and into the deeper tissues. You can see some of the radiologists may choose not to give local anesthetic at all, but we do. So once the local anesthetic is given, then we inject the dye. So you have to shake the dye a bit before you inject it. And you just put your needle in, get into the cortex of the node. So you can see the needle coming in. That bright line is the needle here. And as you need and get into the cortex, just inject into it. There is no need to inject around because it tends to seep out anyway. And that's it. So it's really straightforward. And in the end, you see there's nothing on the skin. And if there's any dye on the skin, you just rub it off. And I'll show you the surgical video now. You see, you hear no sound, do you?
Don't worry, I can talk this through. So at the time of surgery, so you make your standard sentinel lymph node biopsy injection, incision. So in this patient, this is the right breast and the right axilla. And this patient's had a radioisotope injection as well, because we'll be doing a sentinel node biopsy for this patient, dual tracer guided. So make a standard incision that you would normally do. And if you inject the volume that Shama alluded to, so the key thing is to inject very minimal in the lymph gland, then you won't find the black scatter in the axillary fat. So you can just about see that black tinge, and there is no sound at the moment, but you'll have to believe me that when I put the gamma probe on that, this was actually the hot node as well, and it was actually the blue node as well. So you can see the black dye, you can actually see a combination of blue as well there. So it can sometimes be confusing whether it's blue or black, but I think with a slight black tinge, can you see that now? You can see the blue lymphatic there with the black color as well. So in our trial as well, in the pre-ATNEC trial, we found that the dye doesn't interfere with blue, although sometimes it could be confusing. And also it doesn't interfere with pathology. So because you may wonder whether the dye itself interferes with pathology workup, but it doesn't. So you can reassure your pathologist if you're planning to use this technique. So you can see the blue lymphatic leading to the node. And in this particular case, the sentinel lymph node was the tattooed node as well. Although you can't hear the sound now, but you can see the counts on the neo probe going up, just to demonstrate the point. Yeah. Thank you, Shama. So you can switch that on.
We've seen that. So I would say the pros for using carbon dye is that it's inexpensive. You really need no additional skill or training either for radiologist or the surgeon. No additional equipment is required. And the best thing is that it's easy to identify by the surgeon intraoperatively. You don't need any skin marking or localization on the day of the surgery. And no specimen X-ray is required to confirm that you've got the node or not. And the cons, I would say, is basically it's a new practice. So you have to be willing to start if you think that's what will work for you. It can obscure the tissue planes intraoperatively, but only if too much is injected. But we have done that mistake. We have experimented it, and the volume which we are advocating actually works really well. And there is no problem with obscuring tissue planes if small volumes is used. Moving on to marker clips, we use the same marker clips which are used for breast lesions into the axilla as well. In Derby and Burton, we use Hydromark clip because it's easily visible. In fact, it's highly visible, and that's the only one we use. So we use that for our axilla as well. So the good thing about Hydromark is that it remains visible for a long time, even after chemotherapy. And it's due to the embedding gel it is in. So there is a metal bit which is embedded in a hydrogel. And once it's inserted into the patient, it attracts the water molecules and swells and becomes increased in size and very anechoic. I'll show you pictures in a minute. So that's what it is. This is outside before it's injected. There's a metal bit in which you can't see. That's the gel. And when it's in, it just absorbs water and becomes very big and anechoic. So when you insert the marker, all you see is this metal bit, these bright lines. But after a few days, this water gel outside, you see that. So it makes the marker really easy to see. And that's the reason we use it, because it's very easy to see in the nodes as well, like as in breast. So this is a picture after 6 weeks of Hydromark insertion, and you can see it clearly. And this one is, there are two different patients. This is after 12 weeks. And again, you can see it really easily. I haven't got any personal experience, but I've been told that BARD Ultra Core 12 is a very highly visible marker as well and will be good to use. So I'm going to show you a video now using a clip going into the axilla. It's very straightforward for radiologists, but for non-radiologists, it might be helpful. So I will load the video. Can you see it?
Yeah. Yeah.
Okay. So again, patient with arm up, you found the node, and that's the marker clip which we are going to use. This is when it comes out of the packaging. So again, injecting local anesthetic, you may choose not to inject local anesthetic if you wish, but we do. And once the local anesthetic is on, so you can see the needle coming in. And then you have to make a little nick because the insertion needle is slightly thick. So now the marker is coming in through its needle. That's it is. And as you enter into the cortex of the node, you just deploy the marker clip, and it's seen as a bright spot within the gland. So that's the node, and that's the marker. And that's it, really. It's very straightforward. So I'll go back to the presentation.
Yeah,
Okay.
that's good.
So pros for using marker clip is that it's widely in use already. All the radiologists are familiar with it, and there should be really no problem just transferring that practice into the axillary nodes from the breast, and you don't need anything extra for it. Cons is that surgeons may want to have ultrasound localization or skin marking on the day of the surgery, although this is not mandatory within the trial. And then you need specimen X-ray for confirmation. Not hydromark, but other markers may be poorly visible. And there have been in literature citing that markers can extrude out of the node when it shrinks and fibrose. And we know that rarely markers can migrate. So to conclude, I would say that both the techniques work and they are effective. And it's entirely up to the site what they feel comfortable with starting. And I'm happy to take any questions if there are any.
Thank you very much, Shama.
Thanks, Shama. There are some questions in the chat. Peter Barry is asking if you're injecting the black dye only in one node or into several nodes?
Only in one node.
There's another question, Shama. A question is if in smaller nodes, if the hydromarker has been slipping out, have you got any experience on that?
Sorry, could you say that again?
If you noticed that a hydromarker was slipping out from within smaller nodes into the surrounding tissue?
We haven't come across as yet. No, because hydromark does expand, but if you have put it within the node, at least partly it will stay inside the node. So we haven't seen any marker clips outside into the perinodal tissues.
I think, just to sum it here, so I think Vaishali was asking this question. So yes, theoretically it's possible, I think, Vaishali, if that's what you're alluding to.
Has it happened to them? Have you seen, Vaishali, has that happened, or is that your experience?
Sophie, can you unmute Vaishali, please?
Yeah, sure.
Hi, Shama and Amit. Hi, Vaishali here. So, I was just asking, we don't use it in the nodes. We are trying to take part in the trial now, but I was just querying. And also my other question was the bore of the needle is much wider than what you would use for a Magseed. Is that correct?
I think it's 12 gauge. It's not very thick. Bore of which needle are you talking
about? Because if you were using a Magseed instead of a hydromark for a lymph node, Magseed needle is much thinner, which is much nicer for the patient. I'm thinking, I haven't used either for a lymph node, but I'm thinking of putting it in the axilla. Would it be much easier to put a Magseed rather than a hydromark?
No, not at all. It's not very big. Do you use hydromark for breast?
Yeah.
Yeah, so absolutely it goes easily. There's no problem whatsoever with the thickness. I think they both will be equally easy.
If I ask maybe Peter to clarify, what for the Magseed, what size needle do you use?
So I'll come on to that in my talk, but it's an 18 gauge needle. And actually one of the advantages our radiologist says you don't need to make a skin cut. Now, maybe that just saves a little step. But we'll talk about that. I think we have had some problems with hydromarks being extruded before the end. And I guess, I'll come on to this in my talk, and I think Henry alluded to it, that, it then means there's a two-step process because, I think the carbon black dye is a great idea, actually. What I was going to ask, actually, can you put that in the beginning, and do you still need the hydromark? And my question about the more than one node is, do you think it's feasible to mark more than one node rather than have you done it? So, sorry, two questions there.
No, we can, yes, in theory, you could mark many nodes, but we only mark one because obviously it's extra work, really. But I don't see any reason why we couldn't mark more whilst you're there. Just injecting. And sorry, what was the other question? Do you still need hydromark if you've injected dye?
I know you've spoken about hydromark as a secondary sort of, thing you put in the beginning, but I just wonder if you can do away with your markers and just use the black carbon at the very beginning.
Yeah, that's exactly what we are doing. If we are using the carbon dye, we are not using the hydromark.
Okay.
Because dye is visible, really clip has got no role in it.
Yeah.
So for us, we are using carbon dye much more than the clip because it's so straightforward and surgeon can see it. So for us, it's a no-brainer.
Yeah, that seems very logical. I think, I think that's, I must say I enjoyed listening to that.
Shama, that was also one of the questions. The other part of the question was, at what time do you inject the blue dye? At time of diagnosis or just a few days before the surgery?
No, it can be injected at any time. So once we got confident with it, we were injecting at the time of the biopsy. So as soon as you do the biopsy, you just inject the dye because you are there and then patient doesn't need an additional procedure. But it varied with the radiologist. Some were not happy to inject at that time until they got the diagnosis on histology. And then we injected at any time after that, really. Whenever it was comfortable for the patient, if they were coming for pre-op, we would inject at that time. So really, it doesn't matter when you inject it. It's still visible. So whatever was convenient for the team and the patient, we did that. So
Thank you.
Inject at any time.
Yeah, there's another question. Is a vial of the spot dye for single patient use only, or can you use it? I think the syringe, you're drawing it up into syringe.
No, so it comes into a preloaded syringe. All you have to do is attach a needle. It's really simple. You open it, it's already there. You just shake it a bit, attach a green or a blue needle in and inject it. So the black eye which we are using, it's 1 ml, because the thing we've got 5 ml syringe as well, but because you need to inject so little, if you use 5 ml syringe, it's very difficult to get that control of injecting 0.1 ml. And that's why we moved on to 1 ml syringes. And even with that, I usually discard half of it because before you know it, you've injected it all. So leave really tiny amount and then inject it. So yes, if there were multiple nodes you wanted to inject, you can use one syringe for 3-4 nodes easily.
And then question from Donna Edwards. Cost, what is the cost of the black dye compared to a hydromarker?
I think carbon dye is like a tenner. and the hydromark, if I remember correctly, is like £100.
No, it's 50, Shama.
Huh?
Hydromark is around £50.
50.
Yeah, and the black dye, irrespective, you go for the black eye that we now routinely use because it comes in 1 ml syringes. So the radiologist has more control on that. But still the key step is to discard 0.6 ml before you inject into the node, even with a 1 ml syringe. The problem our radiologists face with spot dye is that it's in a 5 ml syringe, so the control is not there. But that's only around £10. I've just put in the chat box the contact. Again, this is something your site would like to explore. The contact for the supplier for the black eye is Michael Morris. So I've put his details in the chat box if anyone would like to touch base with him offline to get more information on the pricing and the supply.
There's another question which I think, Ahmed, we can answer. Vaishali's question was also, how do you localize the lymph node with, I'm guessing HM is hydromarker at the time of surgery?
Yeah, that's completely right, Vaishali. So, and that's the problem if you use hydromark or TrueMark, because although you can mark the node, the surgeon will still need a Google map to locate that node. So you will be adding an extra technique, either Magseed or something else, for the surgeon to go to that node. The alternative is, if you want to keep it low cost, that you just do a dual tracer sentinel node biopsy. And because we know from evidence that most of the times, around 80%, the marked node is the sentinel node, So what he can do is just do a dual tracer sentinel node biopsy. The surgeon takes at least 3 nodes out, and then you do a specimen X-ray. And most of the times, as we know, you will actually find that the clip is there. And you don't need to use any extra localizing method if you don't wish to. I would like to invite now our next speaker, Peter Barry, a consultant oncoplastic breast surgeon at Royal Marsden, London, who will speak regarding Magseed, the localization for the nodes. Thank you, Peter, for coming.
Okay, so again, thanks very much. I'm sorry about the technical difficulties. It's unusual, but anyway, so the Marsden receives an educational grant from SISMEX for hosting surgeons. So that's really, in a way, an invitation to those who want to see how we do TAD. I have no personal COI. Thanks. Next slide. So a Magseed, as many of you by now know, is a 1x5mm paramagnetic titanium alloy, which when used with the probe, if you press the forward button, the detector induces a magnetic current, and that can be then detected and fed back as the 4-digit number. It's got that slightly ribbed textured surface, and that ensures that it doesn't move. And as I mentioned, it's deployed through an 18-gauge needle. Next, thanks. So just for those who haven't used the system before, the probe, the signal is proportional to the or inverse proportional to the distance away from the actual seed. So the closer you are, the higher the counts, and the further away the counts diminish proportionately. Next slide. So you can see the deployment cannula, very standard, simple cannula system, 18 gauge. It's got a little wax bolus in the end so it doesn't fall out when you take off the release mechanism. And the radiologists seem to find it very easy to use. The device above that is the lead pencil. Next slide. So potential benefits is that for the patient, it uncouples it from the day of surgery, as we've heard with other techniques, very similar. No wires, which I think, like Henry, we did not enjoy at all, neither did our patients. And no radioactivity, I guess, is one benefit. From a radiologist's perspective, they find it easy, and it also improves their workflow and planning, so they've got no urgent insertions on the morning of surgery. From the surgeon's perspective, the identification via the localizing probe is very easy through the skin, in fact, probably easier than the breast. And you can combine this with another non-isotope technique, the mag trace, which I won't talk about today, to use that also to detect nodes using the sentinel node method instead of blue dye, for example. Next, thanks. So the downsides have been alluded to indirectly, perhaps. So firstly, the MRI artifact varies according to exactly which sequence is being chosen, but essentially you can see an example of the artifact, which is 3 to 4 centimeters, that signal void with the blush at the edge, and that means that certainly you cannot assess the axilla by MRI. If that's something that you routinely do during neoadjuvant chemotherapy. We don't. And again, you can assess most of the breast as long as it's not near the axillary tail. Next. The other downside is you do need special instruments. We now have a supply of titanium retractors. There are some plastic ones as well that the company does provide. But once you've overcome that, it's really not a big issue. And they're not exactly that costly. One of certainly, well under £100 for any one of these. And then finally is the cost of the reusable. Next point, thanks. Yeah, and so that's probably the most significant cost for most. So after CN1 disease, we did neoadjuvant chemotherapy in appropriate patients, and this is just to take you through our evolution, that before we used Magseeds, we actually used the O12, which was referred to by Puri. So we'd do an FNA, or core of the abnormal node. We'd insert the ultra-core 12 mark, which you can see there. It's deployed again through a tiny needle, but then it actually, with memory, forms a coil, which is about 2 millimeters diameter. And you can see the specimen X-ray there with it within the lymph node. But at the operation, there were problems because, again, as alluded to already with the hydromark, there's no localizing method for this. Yes, if you're lucky and you happen to take it out because it is the sentinel node, and I'll come to that in a moment, where it often isn't, our rates are nowhere near 80%. We'll come back to that. But it was often challenging, and I remember the days when I just couldn't leave the fellow even to do the procedure, and you'd be scouring around looking for this node. And unless it was on the surface, it was quite challenging. Then we had to go to X-ray the nodes with further delays. So it was challenging overall, and so we had to move to something else. It was not there to stay. Next. Thanks. So we then, the context, we'd done over breast procedures, and I think, again, Henry makes the point that when you're comfortable with a device and a technology, you'll tend to continue using it because it's embedded, everyone knows how to do it, and the system's set up for it. So in the axilla, we've now done 145 Magseeds in 136 patients, and most of these are in the context that we're discussing today, in the context of the ATNEC study, of course, which is the post-neoadjuvant targeted axillary dissection. So we've done 75 patients and 79 Magseeds. Next, thanks. Next slide, that's fine. And so this is just, if we just press on the video in the middle, again, shows the deployment device. It just shows this is one of our radiologists. Can we run that? If you just press down the bottom, it should be...
I think it says QuickTime unavailable. I don't know if it needs a specialist player.
Yeah, look, probably you can't play the videos. Okay. Well, anyway, it just shows how it's deployed. It's quite simple. I'll release all these videos for you in a suitable format so you can put them on, YouTube or whatever, so that people can watch them later. Next. So you can, that one works. That's good. So you can see on the left, and you can start the right one as well, we've got a node pre-neoadjuvant chemotherapy, obviously a larger node. It's being targeted and the Magseed's being inserted. And on the right, we've got a post-neoadjuvant chemotherapy node, which is a lot smaller, and you can see looks maybe slightly irregular and fibrotic. And a Magseed's being placed in both of those percutaneously, just to show there it is being deployed now on the left. I think the right one's a bit faster. But Henry made the point, and I think that's very much a universal experience, is that it is very difficult. Our radiologists reported back that it's very difficult to put the Magseed in at the end. The node is harder, it's fibrotic, and of course it's a much smaller target as well. Maybe it's more stable in that it moves less because of maybe some perinodal fibrosis, but it's more challenging. Furthermore, I think someone maybe had said before, what about the O12 markers? Are they visible? Well, in fact, they can become less visible in a node which loses its hypoechoic sort of status. And the O12s, if you get the plane of the ultrasound right, next slide, thanks. Yep. Actually, maybe further slide along, but that's okay. I'll come back to that. But it can be very difficult to see the ultracore 12 when the node has significantly diminished in size. So what we did is that after the first 48 patients where we put the Magseed in at the end of neoadjuvant chemotherapy, we did an audit. These are the patients that had the O12 in place at the time of diagnosis. The Magseed went in usually after chemotherapy, or even maybe a day or two before surgery, very close to surgery. And as I mentioned, that some of the O12s couldn't be seen. Next. And why, again, here's a shot. Just if you press the button once, yeah, you can see, you can actually make out part of the ring on that. Part of it's obscured, and again, you've got to insonate very carefully to get exactly the right direction, and of course that can be challenging in the axilla, so it is a bit difficult. If you get a sort of an end on, you may just see a sort of a slightly echogenic straight line, but you can imagine it's sort of a ring in only 2 dimensions. Next. Next, thanks.
Yeah.
And so, and what was really quite important, if you look at 48 patients, 11 of them, and 12 Magseeds, because there were 2 Magseeds in some patients, were not found within a node. So clearly the Magseeds are not actually placed in the node. They're either adjacent to the node, usually close to the node, but not always. And that's 25% sort of miss rate. Next, thanks. And if you actually go back one step just to show that, so on the bottom there, you've got the node, just an example of how the nodes look with the Magseed as well as the O12 in place on specimen X-ray. Next. Again, you can see now the side-on O12s. It can be difficult to see. Next, thanks. Okay, so then our second step, when we did the audit, we decided, well, let's put the Magseed in from the very beginning, and we call this the sort of de novo Magseed before neoadjuvant chemotherapy, or at least usually before the second cycle, so it might have been after commencement, but very early on in the process, before there's been significant change in the node. And in this de novo phase, we've got 30 Magseeds in 27 patients. And I should add that, you know, our default assessment of response in neoadjuvant chemotherapy at the margin is by ultrasound. MRI use is exceptional. We always determine at the very beginning in our MDT, next please, whether MRI will be required in exceptional situations. Of course it may be, and if it's not required, or the breast primary is over 3 centimeters from the axilla, we'll make sure that the Magseed is placed early, and it's only in exceptional cases where we may delay that for further MRIs. So it's much easier to insert, and that's not me saying that, it's obviously our radiologists telling us that, and we've been using sort of a more formalized questionnaire approach to assess that process. Next. And what we can say is that for the first 30 patients, 29 were found in the node. There was a technical failure during deployment, but essentially the rest were inside the node. So 3.7% miss rate, and I expect that deployment error could have been corrected had it been recognised at the time, and we could have deployed a second Magseed. So that's a significant difference, and if you actually do a formal comparison, we found that was obviously very different to the 25% we'd seen before. So that led to continuation of putting the Magseeds in at the very beginning. Next, thanks. So just a case example, a PET scan of a patient. You can see on the top left both the axillary node and the breast primary, reasonably close together. On the bottom left, very left, you've got the Magseed marker in the actual primary, and then you can see the axillary Magseed in the node and the 2 right ultrasounds on the bottom. Next. And the system works very well. I don't know if we can play this video. Let's see.
Yes, I think this one wasn't playing. Yeah, this is, sorry.
No, okay. All right, next, thanks. So let's look at the types of patients we put in. I think, again, reflecting most people's experience, although we did have some luminal A type cancers, i.e. ER and PGR positive, HER2 negative, and you can see the PCR rate is dismally low there. So I think this is at the very beginning, and we've sort of really stopped doing that. Certainly we don't do TAD in those patients, but you can see the very high response rate as expected in the HER2 positive cohort and the triple negative cohort, as well, interestingly, in the luminal B, although the numbers are small. There were 5 out of 10 who had a complete response. Next. Yeah, and so, and as Henry mentioned as well, and that's well borne out in the literature, that the response rate in the axilla is definitely higher than in the breast. I would say, though, that if you've got a few thousand patients, you will have probably about a dozen patients. We had, I think, a dozen patients in about 800 who did have a discrepancy where they had a PCR in the breast and a non-PCR in the node. So it happens, it's exceptional, and it's got a poorer prognosis, but a very small subgroup indeed. Next, thanks. Actually, sorry. So if you look at the literature on using Magseed in this context, there are a handful of articles now. Our experience is down the bottom. And probably the most relevant recent article is by Simons, which involved Abigail Caudle's group at MD Anderson with 50 Magseeds showing a very high localization rate. Next, thanks. So we've simplified the workflow now, and just to summarize the evolution really, the radiologist is represented by the ultrasound and the patient down the bottom there. I had some help from some youngsters in doing this. So we proved the index node. Next. We then put the O12 marker in initially. Next. That was the second intervention. Next. We then, monitor with chemotherapy, monitor the response to chemotherapy during chemotherapy treatment. Next. We then preoperatively see the patient and tell them they were going to have another marker put in the axilla, which was met with some dismay, to say the least. Next. So further intervention. Next. Yep. So we remarked the node with the Magseed. Next one. And then we did the surgery, of course. Next. Colours have changed. We just keep going, just keep pressing it. Yeah. So it just shows our surgical procedure, which I won't labour. It's been well described. Next. Okay, next, thanks. So we've now taken away the O12 initial marker. Next, thanks. And put the Magseed at the beginning. Next. And clearly that's sort of saved a step in the process. Next. Keep going. That's great. Next. So that's removed one step in the patient journey. And clearly, I think, Amit's team have really alluded to the fact, as have Henry's, that really the next step is to, really try and do things even at the time of biopsy. Assuming the patient's got a neoadjuvant chemotherapy, and it probably begs the question, do you need to really know that? Next. Thanks. Next one. And that's really to try and merge the two, so at the time of biopsy, a marker is put in. Keep going. Thanks. Yep. Okay. So I just want to make a little point, mainly for our radiologists, but also our surgeons who haven't experienced Magseed. We know that Magseed in the breast, if you like, everyone knows the sort of 3 centimetre rule, as it were, that really it's very difficult to resolve 2 Magseeds as separate entities if they're closer than 3 centimetres together due to the current detection technology. And if you look on this example, I've got on the top is the mammogram, of course, where you can see probably the 3 make up 3 Magseed markers. On the bottom, I've got my specimen X-ray with 3 markers triangulating this area, essentially bracketing this area. And if you just next press the button, yeah, I mean, you've got to be careful. So if the 2 markers are within 3 centimeters, it can be very difficult in the breast. But everyone says to me, well, what if you want to put, what if you want to mark 2 nodes in the axilla? And this is why I asked the question, because we've had a few cases now where we know the patient had 2 enlarged nodes at the beginning, but we've only seen fibrosis in 1 node. And the question is, have we missed the second node with fibrosis because it didn't take up isotope or blue dye? In other words, it wasn't a sentinel node. And I didn't make this point, but I'll make it right now, is that our concordance for the Magseed, the marked node being the sentinel node, was only a dismal 56% in our series, which is a little bit lower than certainly the ACOSOG studies in America are about 77%. But actually, the German series, the Center study, which was 50 center, very large study, showed probably about a 60-65% concordance rate. So I think I'm not sure that we would say that if you didn't find the marked node, you're pretty well right 80% of the time. That's not our experience. And that led us to start using, marking 2 nodes. And then the question is, how do you mark 2 nodes? They're going to be closer than 3 centimeters together, but it actually doesn't matter because you take one out and you've got the marker. So the distance between the nodes between the Magseeds is irrelevant in the axilla. And the other thing is the location's binary. It's either in the node or it's not in the node. If it's in the node, then when you take out the node, you remove that Magseed by definition, It's not as though you've got a margin of breast tissue to take, and once it's out, that's out, and then you just shine the probe onto the axilla again, and you take out the second one, and it's very, very easy. Next slide. So one of the big differences this has made to us is that, can we see if we can play the video? Let's see how that goes. Yep. This is my model for neoadjuvant chemotherapy. They're involved nodes, all enlarged at the beginning. They shrivel down and fibrose towards the end of chemotherapy. So if you sort of keep that model in mind, next slide, thanks. Next slide. Yeah, so if you press the button. So here's a Magseed. Well, it's either in or it's out, and this is the point that I was making, and I think Amit, your learning experience with the carbon is similar. You really want it in the node if possible, or very much, in that perinodal fibrosis at the very most. You really don't want it too far, because if you've got a few nodes clustered together, you really don't know which one it's indicating. And you can see there that node is close to 3 or 4 nodes. That Magseed is close to 3 or 4 nodes, but actually not in a node, whereas the other one is. So it's very important that our radiologists understand that it must be actually in the node. Next slide. So again, illustrating that there are some in and some out of the node. And the fact that once you take one of the nodes with the Magseed out, you can localize another one. So there's no problem localizing more than one if that's intended or required. Next. I think I've laboured that point. I don't know if you'll be able to play this video.
It does play. Can you hear the sound or not?
Well, that's amazing. We don't need the sound, actually. I can talk over it. You
Great.
can turn the sound down, actually. So what we're seeing is the 999 signal. And in fact, what I'm saying there is that you can actually just make out the very tip of the Magseed just immediately on extruding some of the axillary tissue. So I'm pointing at it with my Debakis in the left hand. And the probe, that didn't quite make it, but it's sort of 999. We then remove the node, and this just takes a couple of minutes. You might better fall a little bit, but that node will then be removed.
I skip.
It'll be removed pretty quickly. Yep. So that's gone. We then have the count on the node itself, and then we then remove the Magseed, and again, that's quite easy to do. Our pathologists sometimes request us to remove the Magseed so they can do immediate analysis, or sometimes we do OSNA. And just to show you, so the node seed, because it's texturing and the fibrosis, it's really quite embedded in the node, and it's, which is a good thing. It doesn't migrate, it doesn't move, it doesn't extrude, and that gives us great confidence that once it's there, it's put in place, it stays there. So there's the actual Magseed. And now, right, and then we look at the axilla again. This happens to be a 2 Magseed patient, Tad, who had 3 nodes, and we Magseeded 2 of them, the 2 largest. And again, it's just as simple as doing the original one. We dissect the second node. And then the thing I like about this is it takes you directly to the node. There's sort of nothing that you have to look for in terms of visualization. It really is incredibly straightforward. And as I say, now, the thing that's really turned this procedure around for us is that, it's so easy to train SPRs, fellows. I mean, I've even had an SHO do this now, and it really makes a huge difference to the ease of the procedure. Of course, we measure all these nodes to see if they're isotopically hot, because we use technetium-99 isotope as well, although we're converting to magtrace as we speak. And then, of course, we'll check for any residual activity in the axilla after this, and then remove any further axillary nodes. And again, I can't sort of skip my cell, but you can see the signal again, just confirming that it's there. And again, we can remove that Magseed. This is a much smaller node, and you can see the Magseed's been pulled out again. And the point to make, we've got about 4 nodes in this patient, the 2 Magseed nodes, which, just to illustrate here, that was one of them, and this is the other one from the Magseed. They're both cold isotopically, so they were not sentinel nodes, and there are the 2 sentinel nodes on the left. So they're mutually exclusive in this case. And as I mentioned, this is the case in 56% of our patients. Even with 2 Magseeds, we find that this is the case. And you can see those 2 nodes are moderately hot, the count of a couple of hundred, which is certainly way above the baseline for this case. And then we go back to the axilla. And just to show that we do another check at the end, and we can see that there's one final node that we plucked out quickly, which is 5,000, so another hot node, and these were all negative. So it just shows you that, I think there is mutual exclusivity between the biopsied enlarged nodes that have normalized and the sentinel nodes. So I think that 80% we might find it's not quite that high, but let's wait and see. I think that's the end. Thank you.
Thank you very much, Peter. So I'll open this to...
Yeah, I've got a little algorithm. I won't go through that. We can skip through if you just put the next slide, the closing reflections. I think the important things for people, going into ATNEC, and I think the important thing here is, and what we're all aiming to do, and the whole point of the training sessions, which I must say I applaud the organisers for, is to try and get a good quality assessment of the axilla, so that we know patients who are going into ATNEC, really have a very low false negative rate. And so I think there needs to be MDT-wide engagement for this process to work. Not just the radiologist and the surgeon, but really, buy-in from everyone, including medical oncology and the radiotherapist as well. I think you need to make the decision in the Magseed context, of course, I'm speaking now, about whether MRI is going to be required. And then, of course, if the patient's deemed suitable for neoadjuvant chemotherapy, we're very lucky. We have I'm sure everyone else there has excellent radiologists, and there are several in the audience, but we actually, our radiologists just give us the number of nodes they can see that are abnormal at the outset. So we immediately have an idea whether there are 1 to 3 nodes or more than 3, as much as we can. And then we immediately register the patient for ATNEC where possible. And of course, you get the first Magseed free. And then I think the assessment by pathology and just close collaboration is really essential between our radiologists and surgeons to make this work. I think the success of the TAD depends on how good the radiologist is, and as you've heard from Puri already, I mean that part of the procedure is key to making the surgery work. Next slide. I'd like to thank all my colleagues, of course, and of course we all love our radiologists. Next. And just to say that Endomag is providing a platform for you to learn how to do this. And of course, next slide, we do invite anyone who's interested to attend cases at the Marsden. We've got 2 on Monday for anyone who wants to come short notice. So thanks very much. That's all. Thank you.
So does this platform have some training videos as well they can access?
I believe so, and actually we're putting a couple of our own videos. So in fact, on Monday, we're making a video specifically for this platform, Amit, in the context of neoadjuvant chemotherapy. So I think that'll be helpful.
And just to highlight, Peter mentioned this in his presentation, that Endomag, we have industry collaboration with Endomag for sites who are either wishing to take part in ATNEC or already taking part in ATNEC, that they will provide the marker for the node free of cost. If you're using Magseed routinely in your breast for breast localization, they have been very generous for the study. And I'm very thankful for that. Okay, any questions for Peter? Just Peter, if I can ask you. I mean, you mentioned that the MRI is being used very selectively at Royal Marsden. So was this before you decided to use Magseed for the node, or was it after that? So basically, I'm trying to find, it's a chicken and egg situation. What came first?
Yeah, no, the Marsden's always had a tradition for minimizing the use of MRI for response assessment. I mean, it's always had, very good response assessment using ultrasound, and I think that's been a cultural thing way before we heard of Magseed and about these technologies. So really, it was always our practice. And I know we're a little bit off the scale there, because I know many places do use MRI. I wonder if anyone's done a cost-benefit analysis of the use of repeated MRI, to be honest. But of course, there are select occasional cases where we find there's a big discrepancy between, the MR and, maybe with, for example, DCIS and HER2 positive disease, for example. But it's pretty rare. Overall, if it's a invasive carcinoma, let's say triple negative, and again, in the context of a good response, so these phenotypes, we find it's pretty unusual to need MRI assessment more than just the baseline, if even that. And secondly, if it's more than a few centimeters from the axilla, well, you can still do it. You saw that artifact there, and as long as it's not an axillary tail cancer, and then we ratified at the MDT at the very beginning, and then we make sure that we have a sort of team plan.
Yeah, I can, if I can come into that as well. We in Aberdeen don't routinely MRI patients to look at the response. We just, decided the first MDT if they need an MRI scan, because it's more occult on the mammogram or more an M3. Then we go down the route of doing an MRI scan at the end of neoadjuvant chemotherapy. But otherwise, it's just an ultrasound and a mammogram.
Yeah. Just a follow-on question, Peter. Again, for sites who still use MRI scan more compared to ultrasound scan for assessment of response. For those sites, what would be your message if they want to incorporate Magseed for node marking in the neoadjuvant setting, but they still want to use MRI? So how would you suggest that be incorporated in the pathway, you think?
Yeah, I think, have a look at your original MRI and see, what the distance of the node to the primary is. And I think I would be, to play it safe, I'd say if it's 4 centimeters or closer, then I would hold off the Magseed. And then, what you really need to do is probably do it the way, we started out doing it, have your temporary marker, and then put the Magseed at the end. But I think it's, it's going to be, well, I guess you'll know what percentage of cases that is, yeah.
Thank you very much.
Hi everyone, welcome to today's meeting. I think we'll make a start now as it's 5 p.m. and we've got a bit to get through. So firstly, I'd just like to welcome you all to this training webinar, and thank you everyone for coming on a Friday evening especially. This is the second of 2 sessions on axillary node marking training. The session last week was recorded, so we'll be circulating both tonight's session and last week's session as a joint video next week for those who couldn't attend. Just to begin with introductions, so my name's Sophie Cramp and I'm the trial manager for ATNEC based at the University of Warwick. And I'm joined on the call by my colleague Natalie Hammonds, who is our trial coordinator. As of last week, the session has been moderated tonight by 2 members of the ATNEC trial management group, Mr. Amit Goyal and Ms. Beatrix Alsberger. So just to give you an overview of this evening's schedule, so we have 3 talks this evening. The first will be covering the Sirius Pintuition system delivered by Chris Atkin and Dr. Dijkman on behalf of Sirius Medical. Then Mr. Robert Milligan will be giving a talk on node marking using the LOCalizer RFID tag. And then finally, we'll have a talk from Mr. Matthew Rowland using the use of the SAVI Scout reflector marker for marking the involved node as well. So as I mentioned, each talk will be 20 minutes long with a 10-minute Q&A session at the end of each talk. So please, as I said, just direct any questions to the chat box and they'll be picked up by Amit and Beatrix at the end of each talk. So then to begin, I'll pass over to Amit, if you'd like to introduce the first speaker.
So without any further delay, I'll invite Chris Atkin, our first speaker, to introduce his team as well, and to start the first topic on Sirius Pintuition system for node marking.
Well, good evening, everyone, and thanks again, Sophie and the entire ATNEC team for hosting this educational session. Sirius Medical is a company that was founded or spun out of research from the Dutch Cancer Institute and the University of Twente, with research for his PhD from our founder and chief executive, Bram Schmers. We released the first Pintuition system in 2020, and tonight there's myself. I'm the Business Development Director for the UK and Ireland, and Willem Beijer, who is our CCO for the company. And I'd also like to add a big thanks to Floriaan, who's joining us from the ETZ hospital in the Netherlands. Floriaan has, from a radiologist perspective, has probably had the most experience with using Pintuition that we have in the world.
Thank you, Chris.
So you're welcome, Floriaan. Thanks again for joining. So the slide deck is some informative information about how Pintuition works, what it is, and then we also have some videos and animations of its use. So it shouldn't take more than 15 minutes, so we should have plenty of time for Q&A. So there's three main components to the Pintuition system. Looking from left to right, we've got the needle. It's 14 gauge. It comes in two sizes, 12 and 20 centimeter, preloaded with the Pintuition seed. The probe is reusable. It's very durable. All the sensors are baked in a really hard resin, so it's very difficult to fracture or to damage. It's got a 50 millimeter detection range depth, and just one-time calibration at the beginning of the procedure should see it through the entire operation. We'll go through through more detail of the components as we go through the talk. But the base unit, it's quite simple, on-off button at the back. At the front, you can see the screen that gives a navigational experience with our GPS detect. And this is quite hot off the press. This is our second generation detection software, which was recently unveiled at ESSO earlier on this month. So it uses audio and visual smart detection to give more of a navigational experience in seed localization. And then when the probe is directly on top of the seed, we have target lock, which you can see in the screen. It's like a bullseye, a broken circle, that shows when the seed is immediately under the probe. So the needle mentions 14 gauges, 14 gauge. The seed size is about 1.65 by 5.2 millimeters. It's a permanent magnet, and it's encased in biocompatible titanium. It's solid, it's passive, it's very robust, and it can't be broken. The license is up to 180 days ahead of surgery, which includes all soft tissue, including lymph nodes, and image guidance, X-ray, and ultrasound. And it's got an ultrasound enhanced tip to improve visibility. It is MRI conditional, and it will give an artifact, but we'll talk a bit more about that as we go through the presentation. So here you can see on this slide different imaging modalities from obviously the top left, CT, ultrasound, and X-ray. And you can see that the visibility is quite good. And then bottom right, obviously, is the MRI artifact. So it's conditionally safe with up to 3T. In our measurements, we get the artifact, depending on the settings and the equipment, somewhere between 22 millimeters and 59 millimeters radius. So this is obviously something to bear in mind when using the device in this setting. So this is just a short video, and this is actually placement of the Pintuition seed in a lymph node in the axilla. You can see the needle coming in from the top right and the node. And the technique here really to ensure that the seed is in the node is actually go through to the back of the node with the needle And then as you're bringing the needle back, then deploy the seed in the node, rather than trying to push the seed through the node bluntly. So this is particularly good technique for dense hard tissue. You can see the seed nicely deployed. So the base unit we mentioned briefly, it has a volume control on the front at the top right, the calibration button just underneath. The probe is connected just below that, and on screen you will see the navigational guidance and also the depth away from the seed. And then top left, you've simply got just a confirmation visual that shows that the probe is connected, and also the level of the volume. So the seed is, as we mentioned earlier, it's a permanent magnet. It's well controlled and it's robust and designed to withstand any external influence. It doesn't degrade over time, and it's very inert. There's no nickel content, so it should be suitable in most patients. So we have a multi-sensor platform, and this has really enabled us to bring the next generation of detection. And it's based on early user feedback over the last 12 to 14 months, where we've had requests to give the surgeon more information as to where the seed is within the magnetic field that the probe is detecting. So this is just an animation. Before I play it, you can see underneath the probe this sort of hemisphere. Imagine that in like a 360. This is the detection zone for when the GPS navigation part kicks in. It will detect up to 50 millimeters in total depth, but the navigation part kicks in when you're at 35 millimeters away from the seed. So you can see here, as it gets closer, you move into a green zone, and then when you're right on top, that little column it was showing there is 7 millimeters wide. I'll just play that again. So just there, that's the target lock. So that shows exactly when you're right on top of the seed. And again, without the sort of graphics of the cone underneath. So you can use the sort of lateral and up and down, left and right sweep of the seed using this GPS navigation to guide you to the green zone, which means that the seed is under the probe. So that's 35 millimeters away. Moving closer, you get a green signal when the seed is within the diameter of the probe, and then you get the target lock when the seed is directly under the probe. So now we've got a few videos that were performed by Dr. Jose Mendez at the University Hospital of La Paz. And this is looking at, or it's videos from theatre from a primary breast lesion, but obviously the use of Pintuition and GPS detect would be the same in the axilla. Some of these have got sound, and it may take a while to kick in, because apart from the visual navigation, you've got an audible navigation as well. So you get different changes in pitches when you get closer to the seed. And then you hear the target lock, the different change in pitch. You may also see, if you're quick, that at some times there's a little picture of a moon comes up in the screen, and that's sleep mode. So when the probe isn't being used for about 2.5 seconds, it switches off detection just to prevent any inadvertent beeps whilst it's being laid down. And then as soon as the probe is picked up, detection starts immediately. So no sound in this one, but you can see the idea of using the GPS detect to map the area and find out exactly where the seed is. Not sure I've ever seen a marker pen used before, but that's interesting. You can see, oh, you just quickly saw the sleep mode in the top left corner then. So if the tip of the probe goes past the seed, it won't pick it up because it will only look forward, and you can approach the seed from any angle. It doesn't matter. This is just checking the seed position in the lump. And the accuracy is plus or minus 1 millimeter. So that's bang on target lock 9 mil from the seed. And then one other nice feature is you can then also use the probe to see where the seed is in relation to the specimen. And you can see here the surgeon just checking all the way around the specimen to find where the seed is, making sure the margin's good. We also received 510K earlier this year, so we're just about to start our commercial presence in the US. So thank you for listening and watching the movie clips and the animations. This is me. If anybody requires any further information after tonight, then please feel free to reach out to me. Also, you can contact us through our website, www.siriusmedical.com. And I think now we're ready for the Q&A and any insights that Floriaan has to share from his experience with Sirius Pintuition. Thank you all very much.
Thank you, Chris. So first, are you going to share some slides or?
Sorry, was that for me?
Yeah. No, Floriaan doesn't have any slides, just the experience.
Yeah. Oh, I was just going to briefly add that we've been using it for, no, what is it, Chris, now? Over
14 months, 15 months.
Yeah,
you were the first center in the world, Floriaan.
Yeah, oh, great, thanks. Well, it doesn't feel like that because we've adopted it very quickly. We used to use the wire method. And of course, we still sometimes do the wire method, especially when several lesions are very close to each other. But our surgeons are very enthusiastic, and the radiologists as well. The system works, and it's one of those things where when you use it and it works, it's easy, and there's not much difficulty in placing them. The needle is quite sharp, which helps us. And in our experience, especially in the beginning, the company was very quick to respond to our suggestions in making little changes to make it better. So some of the things we've we've noticed is that if you place the marker like you showed in the video, you have to be careful that the marker doesn't move, because of course it's a slippery thing. It's a slippery what is it? We say in Dutch a rice seed. And so the normal markers usually stay where you put them. This marker has a tendency to kind of move. So removing your needle when you're pushing the marker out at the same time and rotating a little bit, that helps, and it keeps the seed in place. And it's a little bit of a learning curve, but it works. Also, it's not a big issue if the seed, like a patient I had yesterday, the seed ended up, it was a very hard lesion, and when I pushed the needle, it went just a little bit through the lesion, and my seed ended up 1 centimeter from the tumor, which was a 1 centimeter tumor. So I can show on the mammograph for the surgeons that exactly where the marker is, where the magnet is, and I will tell them to focus their operation 1 centimeter laterally from this marker, and this is fine. So that's not a big issue. So basically, yeah, we've been using it a lot, even in the axillary lymph nodes, and it works. So I was wondering if anyone had any questions.
Yes, we have got a question. Somebody wants to know what the cost of the system is.
I have no idea.
So absolutely, I mean, it's all in the public domain. The seeds and needle are £160 each, and the base unit is this is in pounds. Base unit is 13,000, and the probe is 3,100.
Thanks very much, Chris. Can I ask you a question? You're probably aware of Magseed. What's the difference between those two systems?
So there's a few differences. So we implant a magnet, and we look for a magnet, whereas Magseed implant a metal seed, and then they magnetize the field. So our system is designed to be used with normal surgical instruments. In some cases, we have seen in a few hospitals that their instruments have been magnetized over time. But you just have to make sure that they're just slightly away from the tip. That's where you get the interference. But one of the beauties with this new GPS detect software is that you will immediately see if you've got interference. Whereas in the past, you weren't quite sure whether you were just off the seed or whether it was the instruments causing interference. So those are the major differences. The probes, again, it's very robust. We've got the 50 millimeter depth, but also now this GPS detect navigation experience is, the feedback we've had is just amazing.
Thank you, Chris.
Thanks, Chris.
You're welcome.
Chris, while we're waiting for the questions, can I ask to clarify, because you mentioned that you can use normal instruments?
Yeah.
So our routine surgical instruments when this particular marker is used.
Yeah.
And you also mentioned that in some cases you have seen that the instruments get magnetized.
Or are magnetized before use. So in their lives, whether somebody's put them on a magnetic, apron on the patient, or they've just somehow, which we don't quite understand, sometimes surgical instruments get magnetized in their life. And then you just need to move them away from the end of the probe if you're experiencing that. I think in Floriaan's hospital, I don't believe your surgeons experience any interference with their instruments.
No, I haven't heard them mention this, so I'm not quite sure, of course, but I do know that they're enthusiastic about it and that it works for them. I think you changed the probe or something.
Yeah, we've got the new detection algorithm.
Yeah, and I think that's the one they're also very enthusiastic about. Yeah, they use it regularly, and we have a pretty high turnover of breast cancer patients.
Yeah, your two of your surgeons did present a poster at ESSO, and that question did come up, and they said that they hadn't experienced it, but we have seen it in some hospitals.
We've got another question. What is the rate of migration after the seed is deployed?
In my experience?
Yeah, that would be good, Floriaan.
Actually, in my own experience, the seeds don't really migrate unless right after placing them, because when I place them, of course, with a 14 gauge needle, I make a little tunnel. and so I make a local pathway, and it's possible for the seed to move a little bit in that pathway, but that happens on like the first day. So when I place it or when I put the patient in a mammogram right after, but we do usually mammography in two directions right after I place it with the ultrasound, and I've never noticed any migration from that point. So when the magnet is not exactly where I want it to be, it was my fault. So yeah, I haven't experienced this. Have you had any experiences with it, Chris, with my colleagues?
We haven't seen anything. I mean, as a company, what we recommend is implant the magnet at least 2 days ahead of surgery. It just allows for any edema, any fluids just to disperse, and for the seed to become a bit more encapsulated. But no, as a rule, and there's nothing in the literature as well, as far as I'm aware, that would lead to any worries of migration.
And of course, this is not a cavity that you would have with a vacuum-assisted biopsy or something like that. Those are big cavities. This is tiny. Of course, one of our wishes as radiologists would still be to have a smaller needle, even
it's on its
smaller
way.
than, yeah. So that's great, because 14 gauge is we would love 16 gauge or something, or at least a little bit smaller than 14. That would make the precision even better and experience even better for the patient, and would help in a lot of these small issues. But it's not a biggie.
Thank you very much, Chris. Can I ask again a technical question? I mean, does the signal decay with time? The magnet that you place. So you said this marker is like a magnet. So
yes.
I think more in the context of neoadjuvant chemotherapy. So I'm coming back to node marking, what we're discussing today. So if you're placing, let's say, the radiologist and the team choose to place this before the patient starts neoadjuvant chemotherapy. So it's good 4 to 6 months when the patient will come back for surgery, and this is placed in the node. So 2 questions for that. One is, you mentioned, Floriaan, your experience regarding migration. That's between when you place it and surgery. So one, if you could like to comment on migration after 4 to 6 months, if you have an experience in that. And the second, Chris, if you or Floriaan could comment, is there any decay in signal?
Mm-hmm. Okay. So your first question, I will have to admit that we don't regularly use it for very long-term follow-up yet. We're working on that, especially in the axillary region, because we do a lot of our follow-up, or actually all of our follow-up, in the neoadjuvant time, which is about 9 months for us. We do that with MRI. And the artifact that we see with the MRI is still quite large. And also outside of that artifact, there's also some trouble with the fat suppression. And that's, for me as a radiologist, is very essential to have a good fat suppression. So as soon as the fat suppression is out, that whole area for me is a bit dubious. So when the seed is only in the axillary lymph node, and I can still see my tumor in the breast, it's fine with MR, and that's what we're going to test now. But for the rest, we actually use normal markers, basic markers, for the tumor and the axillary lymph nodes. Then we do the therapy, and then at the end of the therapy, when the patient is going for surgery, 1 or 2 weeks prior to surgery, we put in the Pintuition seeds. And that's something that works really well for us. Of course, you have the extra cost of the normal markers, but those are relatively cheap. Yeah, that was your first question. Your second question, of course, I haven't experienced any migration, but of course we use them for maybe 2 weeks.
Thank you very much. Can I just again, if there was a site who wants to kind of use your system tomorrow in the neoadjuvant pathway, to mark the involved node, and then the patient goes for neoadjuvant chemotherapy, and then they want to do a targeted dissection or sentinel node biopsy with removal of the marked node. So from your experience, what pathway would you suggest to adopt so that they don't have to go through the learning experience that you may have had to, at the initial stages? What would you suggest a pathway for them so that they can adopt this in their practice? How would you suggest they go about?
I'm not sure I quite understand. how to be able to do this the quickest, or?
Yeah, one of the questions probably, Amit, is to ask is how they follow their patients up. I do see a lot of hospitals that just use ultrasound in these patients, whereas then early placement of the seed is not an issue. And I think as well, from what Patricia was saying, Floriaan, is that it also depends how lateral the primary lesion is to the axilla.
True.
That can have an influence again on whether you place early or whether you place after the last MRI.
Yeah, and I would be totally for using MRI less if that's possible, just because of the simple fact that we have huge waiting lists for our scanners. And if we can do it with ultrasound, that's fine. I think there's also a large group of patients that we can perfectly follow up with ultrasound because it's very in the right hands. It's very sensitive and very accurate, and I can measure the tumor. I can see the lymph nodes. So that's definitely something that would be an easy way in to do your follow up with ultrasound, if that's okay with your surgeons and your oncologists, and if you choose your patients.
So, I mean, what I've understood, just to clarify then, is that if a particular site, normally uses ultrasound scan or is more ultrasound scan dependent rather than on MRI to monitor the neoadjuvant response, so they could actually place your seed at the very start, because they would be monitoring response with ultrasound anyway, and that wouldn't make a difference. For sites who are still using MRI scans or on selected cases, in those cases, they could put a standard clip at the very start, and then after they finish neoadjuvant chemotherapy, they could then use the Pintuition system to mark that clip.
Yep, you ask the radiologist to find the clip and put a seed right next to the clip, because often with a new therapy, we don't see anything anymore, of course. We don't see the lymph nodes. We can hardly recognize the lymph node, but we can find the seed or the clip that's there and put the magnet next to it. That's my daily practice, basically. Yeah.
Thank you. Yeah. Thank you. So, any more questions? I think in that case, I think I'll just summarize by saying that thank you very much for coming for Sirius, Chris and Floriaan, and all your team. I just want to flag up to everyone that I think we have a collaboration agreement with Sirius for the ATNEC study, so that anyone who's planning to use Sirius routinely for their marking for the breast lesions, the agreement with the agreement, Sirius will provide the marker for the node free of cost if the patient is enrolled in ATNEC study. Thank you very much for that. I'll invite Robert Milligan, consultant oncoplastic breast surgeon at Gateshead, and to talk to us about LOCalizer, radiofrequency marking of the node. All yours, Rob. Thank you very much for coming.
So yeah, we're going to talk today about the Hologic wire-free guidance system, so the LOCalizer, with our experience with lymph node localization. And I'm a consultant breast surgeon in Gateshead, and we started using the RFID tags and the LOCalizer system back in June 2019. Next slide, please. So we'll have a quick look at why not wires. I think we all know why not now. We'll look at what the Hologic system kind of entails and our experience with use in the breast and the axilla over the past sort of 2.5 years, and any lessons learned or tips that we may have for you. So I think it's pretty obvious why we don't use guide wires now. Next slide, please, Sophie. And I think it's safe to say that other localization techniques are better for a number of reasons. By decoupling surgery, there's benefits to pretty much every party involved: the surgeons, radiologists, pathologists, the trust, and for the patients most importantly. Next slide, please. So this is a not exhaustive list of the options out there. This is something I came up with maybe a year or so ago, just trying to categorize the trends in localization, really. So initially we've had the guide wires since about the 1970s, and they've been pretty much the staple of breast surgery till the sort of early 2000s. And then the roll technique came into play, which was infiltrating technetium around the tumor, and that was kind of a step forward in terms of where we are now, but it's kind of dispersed radioactivity, and there's some issues with it not being particularly focal and a short half-life. Then the next kind of major step, the third generation for me, was the radioactive iodine seed, where the radioactivity was focused into a small capsule or a seed, and suddenly the focus is a lot better with the probe. So the localization was essentially better than being injected around the tumor. But with any radioactivity, there's a lot of difficulties, and particularly related to the regulation around radioactivity. And in the UK, it's the RSAC license, and it's a very lengthy setup process. But once it's up and running, it's relatively cheap and very good. And there's good studies to show that it's helped with re-excision rates. The fourth generation of localization for me is really taking the radioactivity back out of the seed. So there's a number of options here: the Magseed, SAVI Scout, the Pintuition, and then the Moly surgical as well. So they're all sort of, for me, in that category, small non-radioactive seeds, which generally very well uptaken really amongst surgeons, and they definitely do the job. And for me, the fifth generation is the radiofrequency ID tags. And I think the difference here between these and the others is adding in some degree of intelligence. So it's the ability for that tag to hold and store some information which is accessible to the surgeon at the time. At the minute, that is just a number essentially, which tells you which tag it is that you're identifying. You have multiple tags in the breast, but that could be used for other things in the future, and it's helpful certainly if there's multiple tumor sites or areas that need removing. It reduces some of the difficulties that I saw with iodine seed in the past, where you didn't quite know if you were scanning seed number 1 or seed number 3 within the breast. The equipment's pretty cheap, it's easy to set up, and got very small probes, so it's something that we kind of like in our unit. The idea here that we've moved on for guide wires, and within about 10 years we've got so much choice, I think is fantastic. It's a really good way that the market has moved, relying on the market forces, that we're here as surgeons, and it's like picking a car now. You pick the thing that suits you rather than being told you have to get the bus or ride your bike. So yeah, it's really good. Next page, please. So the tag here, it's a passive 11 by 2 millimeter RFID tag. It's preloaded in 12 gauge delivery needles. It's non-radioactive radiofrequency identification technology that allows this to work and gives you this unique ID for each tag when used on the detector. And it's similar to a microchip that would be used to identify pets. Next slide, please. So this slide here shows you the setup, and there's the needle and the tag. We can see the handheld reader, which has got a 29 millimeter marker on, and that's showing from the tip of the probe that's been inserted to it to the tag that's on the table. And what this does is, either with the LOCalizer handheld reader itself, there's a circular area at the end, and that will pick up in a non-sterile field, where the tag is within the breast. So you can just identify that it's in the breast. It gives you a distance, and it's a fairly crude marking. And then in theatre, the handheld probe can, the handheld reader can be put in a sterile packet, and then the probe sort of inserted through a little valve in there, a bit like headphones into an old CD player or Walkman, and that will give you a sterile setup, which is handheld, single-use probe, and much more accurate than just the reader by itself. Next slide, please. So this shows it in real size. I'm no orthopedic surgeon. These are 7.5 gloves and hands that I've got. That's a Beijer for scale. So it really is a small unit, and that's very handy when it comes to sort of having within the operating table or moving cross sites, which we did quite a lot during COVID. Next slide, please. So the cost's approximately £4,500 per handheld reader. Get a warranty with that. You don't need to service these. Consumables, about £270 for everything per case. So the sterile unit, the probe, the needle, and the tag. It's CE marked for insertion anytime pre-op, and it's safe with MRI scan. There's approximately 3 centimeter sort of bloom or signal loss reported around the tag, but it's safe. But I think with most of these things that are essentially not the patient. If they're in the MRI and there's any metal associated with them, you're going to get some signal loss, which is less than desirable for, what we use the MRI for. Next slide, please. So just some images in the breast tissue of the tag and how it sits on the mammograms, on ultrasound scan, and on a wide local excision specimen in the breast. So fairly straightforward and similar to the other types of technologies out there. Next slide, please. So published literature, really 2010 in America, they started popping these into turkey breasts and cutting them out to show that they were safe, and gradually moved on, as you go through to the next slide, please, to some clinical studies on patients, taking out benign lesions, a few cancers. There's relatively small studies, the maximum I think there with 30 patients in, but all have shown that it was fairly safe. There was an anti-slip capsule put in because one of the studies showed that they were quite mobile within the early kind of breast lesions or breast tissue. So they got an anti-migratory sheath developed from then. And then next slide, please. And then we published last year, about a year ago, our first kind of 150 cases that we'd done in our unit, essentially showing that it was safe technology and a switch, from our experience to guide wires. Next slide, please. So I'll just talk you through a little bit about that case and then on to what we've used it for with the auxiliary nodes. So essentially the experience showed that you can safely use the RFID tags in the UK. It can have a lot of benefits over guide wires, and it's effective for screening patients, symptomatic patients, and in breasts and axillaries. Next slide, please. So briefly looking at the methods, all the histology was discussed, margins were 1 millimeter, and we performed re-excisions and mastectomies on patients who had positive margins. Next slide. All of the tags were located, they were all identified within the breast, so we didn't have any issues within the study period of finding a tag pre-incision. They were all retrieved and excised. On occasion, we did notice that the superficially placed tags, so if there was a superficial impalpable cancer and a tag in it, as we dissected sort of above the tumor in the superficial plane, occasionally you would see the tip of the tag popping out during dissection. It wasn't particularly common, but we changed our practice to put the tags just next to or just deep to or at the posterior aspect of the lesions, a bit like what Floriaan was saying there. Put the tag just next to it or just deep to it to try and reduce that. Next slide, please. So our results, re-excision rates were low, so it's a trusted technique for us. After sort of 150 cases, we were at 8% re-excision, and we'd done 6 targeted dissections at the time and had no problems with them. Next slide, please. So briefly speaking about the pathway that we currently use for our lymph nodes that need targeting, essentially anyone with a cancer is going to have a diagnostic ultrasound scan if they're fit to proceed to surgery. And of those, some will have no biopsy and go on to sentinel node biopsy. Some patients will have a biopsy taken if there's an abnormal node. And for some, probably the majority, but not all of the patients, a hydromark clip is usually placed within the tag. There was some discussion amongst our radiologists about a national shortage of titanium and of marker clips, so they probably over the last 6 months have put slightly less marker clips in the index biopsy than they had done previously. The patients who had a benign biopsy again would have sentinel lymph node biopsy, and of those that had biopsies that were malignant, they pretty much went into 2 groups. So the first group is the primary axillary node or primary auxiliary node clearance or an RFID tag inserted at that time and a targeted dissection. And this tends to be for the non-responding type patients with neoadjuvant chemo, so the ER positives and the HER2 negative cohort of patients. For the more chemo-responsive tumour types, they go off and have neoadjuvant chemotherapy. These will all have a marker clip placed in, some of them, as I say, as a second procedure if they've not had one put in at the time of biopsy, and they go off and have chemotherapy. Towards the end of chemotherapy, they'll have a post-treatment MRI scan, at which point we will know sort of the state of the axilla in the breast, and then the patients will go for a similar either axillary node clearance if there's obvious remaining disease after chemotherapy, or get the tag put in at that point and undergo sort of targeted dissection or enhanced sentinel node biopsy. Next slide, please. So it's just showing a thickened cortex of a metastatic lymph node on a patient I operated on recently. Next slide. It's showing the tags just been inserted into the node. And next slide. There's another view of the lymph node with the tag inside. So although these tags they're bigger than the alternatives on the market, they do sit in the node, and we haven't really had any problems with the tags being miles away from the node or away from it. They tend to sit in. I don't know if the cortex maybe holds them in a bit more than a breast tumor might, but we've found them quite successful, and they do sit within the nodes. Certainly the nodes that haven't had chemotherapy. Next slide. So we developed a tag sheet, which is something that's been very useful for us for when patients have their tags inserted. We used to use similar things for guide wires, and patients in the breast screening program all had a breast screening packet. So on the morning of surgery, they'd go to the breast unit and they'd have their wire put in, and then some kind of sheet would come back to the theatre operating suite, and you'd be delivered that by the time the patient had surgery. With patients now not going down to the breast unit, we still wanted to get a tag sheet, and rather than having to ferry it around the hospital, we upload this to our imaging portal. So next to the mammograms, or when the tag's inserted, you'll see it on that ultrasound scan report. We see the sheet, and the radiologist will write down what the unique tag ID number is, where the site is, where it appears to be in the breast or the axilla. And that's been really helpful for us, and certainly reducing the paperwork has been useful too. Next slide. So looking at our lymph nodes, we reviewed our practice for a couple of years up till June this year. And in total, we'd inserted 679 tags in 578 women. Of those, 31 were inserted into axillary lymph nodes in 31 women, and a bit of a varied age range, as you'd expect. Next slide, please. So 9 were targeted to clipped metastatic nodes after neoadjuvant chemotherapy, as Floriaan described earlier. And 9 is not a ginormous number, to be honest, in a procedure that we do fairly routinely. And I was just having a think as to why that was. And essentially, I think COVID came in and scuppered our plans for what was normal treatment for us for a fair while. So patients weren't going for neoadjuvant chemotherapy as much as they were outside. ABS guidance was that patients with positive nodes should go for a clearance rather than targeted dissection to reduce the need for a second operation when other patients weren't able to get surgery. So I think we definitely reduced the number of cases that we were being more conservative on throughout the breast and the axilla during that time. 19 of our patients were targeted to metastatic nodes who essentially had their targeted dissection as a primary axillary treatment, so the ER positive, HER2 negative patients with a low volume disease in the axilla, and we had 2 targeted for diagnostic purposes. Next slide, please. So all of the tags and the nodes were successfully excised, and they were all confirmed by a tag site reaction, so usually from the biopsy or the biopsy clip reaction. No complications were reported regarding the tag insertion or retrieval, so no difference there at all. And the average was 4 nodes excised per case. There was a large range there from 1 to 17 nodes. I don't know what happened with the 17 node sample. I don't know if the surgeon sneezed at the time, or if there was must have been some lobular disease or something there that they've obviously done a clearance at the time. There are a few patients that had less nodes than you'd think, and I think that happens more likely after patients have had chemotherapy. We've had patients having clearances where the pathologist can only find on pathology 4 or 5 nodes in the whole axillary clearance, and that goes with what the radiologists are saying about they can't see many nodes and they're just targeting the clip. But on average, patients had sort of two lymph nodes removed, and that probably represents the high number of patients having a primary axillary procedure rather than neoadjuvant chemo. Next slide, please. So in all expected cases, the metastatic nodes were retrieved. They were all macrometastatic disease at that time, as you'd probably expect by being visible on imaging. In 7 of the cases, there were no metastasis, and that's because 5 were post-neoadjuvant chemo and they had PCR confirmed in the node, and 2 were benign nodes on diagnostic biopsy. Next slide, please. 6 women went on to have completion clearances, so there was a 1 out of 1, a 2 out of 2, or 2 out of 2s, and a couple of cases with more than 2 nodes positive. We try and avoid, generally speaking, doing targeted dissections primarily on lobular cancers. I think we're likely to get caught out and leave disease behind, so I would probably favour an axillary clearance up front, and I just wonder if some of those patients were that. The lower number of nodes, the 1 and the 2 nodes, I think were patients who'd had neoadjuvant chemotherapy and had residual disease. Despite all the clearances, as we'd expect, we only found a tiny bit of disease, 2 further micromets in 2 women. So again, we're probably doing this for the wrong reasons. Next slide, please. Essentially, there's a very short learning curve for this. I think all surgical teams will have people that are keener to get started on things and some that hold back. Same with radiology. It's a fact of life, normal distribution of people, but everyone's taken to new technique like ducts to water, no problems at all. The patient feedback's been really good. We found using the unique tag IDs really useful to identify separate lesions within the breast and the axillary node, so you know exactly what it is that you're identifying at the time, and that is helpful, particularly if you've got some sort of B3 lesions needing excision alongside cancers. I think it is very helpful to know exactly what you're taking out. The specimen handling in pathology, dead straightforward. I think these things aren't sharp like guide wires are, so our pathologists are very happy using this, and with there being no radioactivity there, pathologists are very happy. Very easy disposal. If we find them in theatre, you know, if they do present themselves during a superficial case, then they can be just thrown away in the normal sort of routine clinical waste. And we found the system really useful for multi-site operating, particularly with COVID-19, where half of us were shipped out to the private sector and the other half kept our theatres on the usual NHS site. Next slide, please. We've not noticed any significant procedural difficulty or complication, and that's with tag insertions, localizations or excisions. We've had no failed any of the above. Breast and axillary lymph nodes, both equally straightforward. I think dense tissue, as Floriaan had mentioned earlier, it's really important to push the tag forward when the radiologists are pulling the needle back. And I think the larger needle with the RFID tags, I think, is the more difficult thing, particularly with dense breasts, particularly dense fibrotic breasts. System's small, robust and ergonomic, really useful for surgery where we're using remote incisions, which is what I like to do in the breast. So it just keeps out your way. It's very small probe. And in our unit, the tags have fully replaced guide wires. We had during COVID a slight issue with supply chain at some point. I think a couple of the surgeons had to use guide wire for 1 or 2 cases, but nothing else. And none of us have any regrets with the fact we've moved forward and away from guide wires. Next slide, please. So yeah, in conclusion, the tags are safe and effective to localize lymph nodes for targeted axillary dissection. Next slide. Just some acknowledgements for the team in the unit who've helped with the data collection and writing up the targeted node study. And next slide, please. Any questions?
Thanks, Rob. There are some questions in the chat, also some comments. So one of the comments was the Hologic system would be better if it's not disposable. You seem to be quite liking getting rid of the probe. The other thing is we're using in Aberdeen also the RF tags, and Charlotte Ives in Exeter has also noticed when they're placed into superficial lesions and especially anterior to the lesion you're looking at, they can fall out. So we had 2 falling out, and Charlotte noticed 2 falling out, and you noticed that as well. And we have now an agreement with the radiologist to place the RF tags behind the lesion if possible. Most likely reason we thought in our unit was because the seed is 11 millimeters compared to the tag is 11 millimeters compared to 5 millimeter seeds. Is that also your thinking?
Yeah, so the first point you mentioned that the tags are the probes are disposable. When we were looking at introducing this, we'd got some funding agreed from the charity to assist with radioactive iodine seeds, which is the route we were going down initially. And we switched when the Hologic system, I was aware of it in America, and when it came out, I said that we need to have a look at this and see if it suits our purposes. And there was a bit of arguments with management moving from guide wires to a new system. And one of the things they said, right, you need to make this as cheap as you can because we're not going to pay for it otherwise. So I actually used the probe in, like we would do with the sentinel node probe. So I said, right, okay, we've got a list and we've got a probe here. We'll use it for 4 cases on the list and we'll put it in a sterile holder like we do with the sentinel node probe, like we would do with a Doppler for doing perforator flaps. You know, we'll do this, and it between each case, just to check it works, I would try it. I had a test tag in one of the packets, and it works perfectly well, perfectly robust system. They just can't be sterilized through the autoclave. So I think it's a really good system. I think it's probably how Hologic make their money, by making it reusable, because the rest of the equipment, by making it, disposable, because the equipment otherwise is relatively cheap in terms of the setup. So it definitely does work, and it definitely does wind me up that we have to pay each time for something that would be perfectly safe to use. But I got a slap on the wrist for doing that and trying to make things a bit cheaper when management asked. So said, fine, it's not worth fighting this or trying to do it, and we'll just use it the way it's meant, because I think there's something written on it where essentially you're not licensed if you use it. It says single-use disposable item, and I think if there was any problems, then the trust is going to be liable for whatever those problems are. I don't know. I don't think there's nothing's going to happen, but they won't do it. So yeah, I think it'd be much better if it was reusable from the probe point of view, but it works fine without. In terms of the superficial lesions, from the very first time we had the tags, and I had been trained in the iodine seeds, and they're tiny little things and great, except for the other issues with them. They were bigger, and I said these need to be smaller. If they're going to be competitive in the market, you need them smaller. And the way that's manifested itself as a problem is with these superficial lesions. I think you do see them popping up, or even deeper lesions if you cut near to where they are, and particularly if they've not been in the breast for that long and not embedded in a proper capsule. So within a good 7 days or so, if they've had a bit of hematoma, I do think that there's possibility that they can migrate. So if I'm doing a periareolar incision, so operating away from where the tumor is or at the side of the breast, as I'm doing the superficial dissection, one, I'll be aware where the tumor is up front, where we know where to anticipate it from before I've made the incision. And secondly, I do keep an eye out, because if you do all your superficial dissection and don't identify where it is, you could easily find that the tag's popped out for the superficial lesions. So I will always put a marker there, and that's usually I put a stitch just over where I think the tumor is when I've done that dissection, and it's not been a major issue. If the seed pops, it's a centimetre up through the tissues, it's not been a big issue because I've got it marked by eyeball anyway. So. Yeah.
You mentioned that you put in the tag before the surgery, quite a few days before the surgery. Another question is, how long was your median time prior the surgery you will put in the tag?
I think on the main study we did, it was at least a week beforehand. What our radiologists don't like is having a load of cases dumped on them the week before an operation. So they like to have the requests in as early as we've seen the patients. So we usually have maybe a 2 to 3 week window between us seeing our screening or symptomatic patients and operating. And when we see them diagnosed and make the plan, we put the requests in, and our radiologists will try and get them done as timely as possible. We don't have a limit, but it suits everyone to be in as soon as feasibly possible, really. So yeah.
The other thing is, we've been promised smaller RF tags for the past 12 months. Have you got an idea? Have you been in contact, and have you been promised the tags coming soon, the smaller tags coming soon?
Am I privy to some insider information? Yes, I am. And yes, there's something on the cards, and it's probably going to be about a year before everything's been tested and through. Yeah, I was asking the same thing. When's this going to happen? And I think provided they get everything tested, and there's a big backlog for the regulators, I think, at the minute with COVID. I mean, I don't know if they can test from home or whatever. So I think everything's taken ages. So, but yeah, I think within about 12 months or so, is what we're probably expecting when we can receive the version 2, if you like, which should be smaller. How much smaller, no one knows. Whether it will work as well, no one knows, but it will be smaller. So that's all I know, and I'll probably get
yes,
off the saying.
Good. I think we covered most of the, or basically, or tried to cover most of the questions, all of the questions. So.
Thanks, Matrix. Rob, can I ask you a question again, more for node marking, just to kind of summarize the session for yourself? Is you suggested in your pathway that you use a standard clip for patients going for neoadjuvant chemotherapy. So you mark the lymph node with a standard clip, and then the patient has neoadjuvant chemotherapy. And then depending on the imaging response, which makes sense, that if there's a good responder, then you mark the clip with the RF tag. Now, keeping in mind the size of the tag, what's your experience from your radiologist point of view in actually using that to mark this clip? I mean, just for the benefit of everyone else when they go back and talk to their teams?
Yeah, the radiologists have been fine with it. They're a proactive bunch, and they prefer this to guide wires generally. I think it's improved their working life, and they haven't mentioned anything. I speak to them regularly about this, and they've not found any particular difficulties with the lymph nodes. I think the size of it, people get quite worried, particularly surgeons saying, well, how am I going to remove a lymph node if this is such a big tag? Radiologists, again, when we're doing this kind of surgery, particularly post-neoadjuvant chemotherapy where there's a good response. So these are the types of patients who have small nodes. Often the other ones, the primary dissections, they'll sit in the node straight forward. But the ones you're talking about, the post-neoadjuvant, they're really targeting the clip or the fibrotic node if it's there. And we've not had any issues from the results that we've had from the cases that we've done. We've had no failed, and beyond that, for the next sort of 3 or 4 months beyond that, we've not had any times where patients have had their neoadjuvant chemo, they've had a clip node, they've had a tag put in, and we've not identified it. So it's fairly straightforward. In an ideal world, we would target everything early on, probably. I guess the neoadjuvant, if you're going to go and do a clearance, you'd say, well, why are you going to put a tag in at the beginning? Why would you put in something, a waste of money, if you can put a cheaper clip in at the beginning? The MRI scan, again, is something where we're trying to phase them out. We've introduced contrast enhanced spectral mammography recently, and we're kind of doing any patients who have a neoadjuvant chemo alongside their MRI, they're having a contrast enhanced mammogram. So with a view to potentially adding that as an adjunct to ultrasound scan as well to see what the response is like. So we're fairly early on in the pathway from that point of view. But yeah, these could be put in. Our radiologists haven't had any issues, so they could be put in pre-neoadjuvant. There's certainly they're passive, so there's no problems time-wise, and they've not been a problem in the ones we have had who've had neoadjuvant chemo. I think more of the issue, Amit, would potentially be if you've got a hydromark clip in, potentially if they've been in for a long period of time, some of the jelly around the outside can degrade and make it more difficult for the radiologist to find the area. But again, that's not been a massive issue from a breast from an axilla point of view, but it has been known in the breast in the past.
Well, thank you. And this doesn't interfere with MRI scan, isn't it?
Yeah, it does. You get some bloom. You can do it. It's perfectly safe to do, but you'll get some bloom with the MRI scan. So you wouldn't be assessing a disease response with a tag sitting in there.
Rob?
Hello.
There's another question. How long is the RF tag licensed to stay in the breast?
Anytime. It just has to be put in with the intention of removing it.
Yeah.
So it causes no harm if it stays there. It can be in for 50 years if you want, but yeah, usually they're in for a few months maximum.
Okay, thank you very much, Rob. I'll invite Mr. Matthew Rowland, who's consultant oncoplastic breast surgeon at Liverpool, and to take us through SAVI Scout Reflector to mark the node.
So in Liverpool, we decided to move to SAVI Scout principally because some of the surgeons wanted to pursue axillary conservation, and at the time SAVI Scout had obviously CE mark and license for the axilla as well as the breast, and potentially to stay in for life, so that we could use it as our upfront marker clip rather than have to put in a hydrogel and then localize that later on. Next slide. I have no commercial or other links to Merit or SAVI Scout, but they obviously have provided me with some of the materials for the slides. Next slide. So I'll quickly go over an introduction to the Scout technology itself. In particular, our tips and tricks for use in the axilla. I'll show you some of our Scout guided TAD data, and that we find it incredibly easy to use. And then clearly I'm happy for any questions. Next slide. So this is a reflector. The SAVI Scout within the breast is essentially an inert reflector for radiofrequency infrared waves that come from the probe itself. Next slide. So it's only a few millimeters, but you can see it with the naked eye. It has essentially 2 antennae, and it's made of nitinol. So this has very little, if any, artifact in an MR scanner. And we've confirmed that with patients that we've had these inserted into the breast and have gone on to have an MRI. And our radiologists do not feel it inhibits their reporting of the MRI at all. We haven't probably MR'd anyone that I can think of with one in a node in an axilla, but likewise, I can't see if it causes no issues within the breast that it would cause issues sitting within a node. The other thing is, because it's nitinol, there is no issue with people that have or report nickel allergy having this inserted. Next slide. So essentially the probe that you have fires infrared waves, which are then reflected back from the antennae, and you get both a signal which in kind of speed and intensity tells you how accurate you are in terms of the probe facing the reflector, but also you'll get a depth in terms of millimeters of how far away the tip of the reflector is from the probe. Next slide. So you can obviously localize in 360 degrees. What you'll see on the side of the probe there is 2 little purple lines. So if you ideally there's 2 purple lines on the other side of the probe as well. So if you like at 3 and 9 o'clock, and if you get the antennae to line up with those purple lines, you'll get the strongest cadence, so that you know that you're effectively facing the center of the reflector, and the speed with which the reflection occurs gives you how far away you are in terms of a distance, plus or minus 1 millimeter. Next slide. So that's just to demonstrate the cadence, that if you've got the antennae essentially lined up with the purple marks on the side, you get an incredibly fast and loud signal. If you've got them focused the other way, it's slower, but you still get your depth gauge. So the Merit say that you can get a signal at least up to 60 millimeters away. We've certainly not struggled even in a deep and ptotic breast. Certainly, I don't see that people would have any difficulty localizing in the axilla. Next slide. So this is the monitor that you have in theatre, and obviously it gives you there your the depth away between the probe and the reflector. We have it set up on a trolley, and essentially the monitor that we have in theatre stays in theatre, but there is a monitor that goes to the radiology department so that they can confirm a signal at insertion. And they put that in their report, that they've obviously inserted the signal, they've got the reflector, they have a clear signal, and then you know that your technology is working and it does not need to be checked again. And this includes all of our patients that are having these inserted prior to neoadjuvant chemotherapy. Purely from a breast point of view, our radiologists in their screening assessment will now put one in at diagnosis at the time of core biopsy for an M5U5P1 lesion, because then the patient never has to come back for either a hydrogel marker clip or localization. And it means at the time in the assessment clinic, even if they wish to be repatriated to the other hospital in Liverpool, because we both use Scout technology, the patient is ready just to be listed on an operating list. Next slide. The manufacturer in theory says that there are a couple of things that could inhibit the performance. They've mentioned about halogen or lights. We've never found this either in the radiology department or in theatre. In terms of hematoma, we have had a couple in the breast that at insertion, the radiologist or advanced practitioner has commented that there is a bit of hematoma and they've not had the best signal. What we have done is we've just rechecked the signal prior to clinic and prior to surgery, because obviously we have one of these in radiology and we've picked up the signal again, so then we're confident that we've got a good signal before theatre. I think the longest we've had to wait is about 3 weeks from a poor signal to having a decent signal again. In theory, a strong pulse from electrocautery could disable the signal. We think we may have had one of these at the time of performing a wide local excision, but in essence, the surgeon had the specimen in their hand and was just finishing off the dissection. So it's never impeded us resecting the tumour, and most of us tend to put either a mark or a suture over the signal prior to doing the final dissection, as we used to do with roll or wire. Next slide. So our pathway, particularly for the axilla, is that if we identify a 3 to 5 nodes as part of either a symptomatic or screening assessment, those nodes preferentially undergo core biopsy. A couple of practitioners still prefer to do FNAC. And if the node is obviously pathological, we discuss at MDT their suitability for targeted axillary dissection. In our unit, it tends to be people with a single node or selected with 2 nodes. If we feel that they've got 3 or more, then for us, that's an indication for a staging CT and a clearance rather than targeted axillary dissection. We would, however, then place the Scout, obviously via ultrasound guidance, before they go on to have their neoadjuvant chemotherapy. If they're not having neoadjuvant chemotherapy, then we just place it prior to surgery. We don't routinely check the position with a mammogram, clearly in the axilla, but we do in the breast. And occasionally some of them, as I'll show you, are picked up on the extended CC part of the mammogram. Our radiologists check the signal as they insert to confirm that obviously the Scout is detectable. Our agreement is now, in view of the couple of cases with hematoma, that if we had poor signal, we would check it again before surgery, with a view that if we still had a poor signal, we can then plan an alternative form of localization. Historically, we used roll, so we would probably just roll in the periphery of the Scout. As I mentioned, we're therefore using it as our marker as well as our localization, so we don't tend to need to put in a hydrogel marker clip. And from a financial point of view, it was part of how we made the business case that £90 or so per hydrogel clip it was a significant saving, but also it meant that you've got a significant reduction in the number of patients going backwards and forwards to radiology, freeing up radiologists' time, and therefore the fewer number of trips could be condensed into planned ultrasound lists. Next slide. My radiology colleagues provided me, this is all they need to do it. So essentially on the far right is the deployment device with obviously the Scout inside it. But other than that, they need nothing more than they would do to deploy a hydrogel marker. Next slide. And this is one of my colleagues. Essentially, all of our radiology consultants and practitioners say that this is no more technically demanding than placing a hydrogel marker clip. And they aim to put it within the lesion. Occasionally, it will sit partially within the lesion or on the periphery, but we've not noticed any migration. We had four consultant radiologists, 2 fellows, and about 5 advanced practitioners. And for the first few, they all buddied up, so 2 on each insertion, so that essentially they were learning off each other. And that meant within our first 20 cases, we pretty much had all of our practitioners able to do it independently without any issues. Next slide. So this is just showing the deployment of the device into a pathological lymph node. Next slide. And then this is a patient that came back for their mid-chemotherapy repeat ultrasound of the breast and axilla. And it's just showing you that you can still see the Scout and the 2 antennae sat within the lymph node that is obviously returning to looking more anatomically normal. It is not always particularly easy, particularly in the breast, to find the small Scout, but because radiology have a probe console in radiology, what they do is they just put the probe on, listen to the signal, and then they can either find it again or essentially say, clearly the pathological tumour is no longer visible in keeping with a radiological complete response, but I can still get the signal from the Scout, so suitable for Scout wide local excision at the end of chemotherapy. Next slide. And this is one of my patients who obviously had a large pathological node in the axilla and a pathological breast cancer that were both marked with Scout. She was part of the NEO21 trial and had a very high Oncotype DX score. So she went off and had neoadjuvant chemotherapy with a complete radiological response in the breast and the axilla, and then went on to have a Scout-guided wide local excision and targeted axillary dissection. Next slide. So as a double safety check, we still check that we have a signal with the Scout probe in the anaesthetic room as part of our check before the patient goes to sleep, so that in theory we could divert them out of the anaesthetic room for either an ultrasound skin mark or an alternative localization. We're likely to stop doing this because we haven't had to do it in 300 breast patients and any of our targeted axillary dissections. And we're comfortable that if the radiology practitioners say they've got a decent signal at insertion, we don't need to check it until the patient's on the table. When we're actually doing the Scout dissection in the axilla, I tend to say to the trainees in particular, I don't want them to shove the probe right up close to a node, because there is the possibility of deactivating the Scout if you get within 1 to 2 millimeters of it. So particularly, it's probably my paranoia because I'm hands off. I tend to say to them, I want them to have a good idea of where the node is, ideally have a Babcock around it, and then confirm that they've got a signal. So if deactivation did occur, we already know what we're taking out. However, we've not actually deactivated any of them. So again, it's me being cautious at this stage. We do tend to confirm the signal with the node excised. Some of us like to still X-ray the node to document that we have removed the targeted one, and then we tend to complete our targeted dissection with 3 other hot and blue nodes. This is just to show, this is the same lady that I showed you the mammogram of, and albeit that she had a huge node with the scout in the middle prior to chemotherapy, at the end that felt like an intact node with the just one antennae palpable outside, and we think that that was probably fibrosis from the macromet, the white blob in the center, because the whole thing actually felt like a lymph node. But essentially there's no migration, the scout stays nicely within the specimen. Next slide. As I said, inferring from our experience in the breast, if you had a hematoma and a poor signal at insertion in the axilla, we would say either check in the anaesthetic room or give it a couple of weeks for the hematoma to resolve. But as I said, we haven't had that for any of the axillary scouts. Again, as I said, in theory, deactivation can occur if you get the probe and the scout almost touching one another. But again, we've never had that. And I think it's far more likely to happen in the axilla than it would be in the breast. Next slide. So from our own data, obviously we were performing some TADs before scout, predominantly with a roll to a hydrogel clip. So we've done 24 targeted axillary dissections, 17 of them have been scout based. In essence, most of our cases have been single nodes, but we've started doing it for a couple where there've been more than one node. And we have a couple of cases that the scouts are in place and they're having neoadjuvant therapy, so their surgery hasn't occurred as yet. Out of the 26 that we've localized for TAD, we've never had a failure of localization, and we've never had a reported complication at insertion, and that includes the 19 of 19 scouts inserted. Next slide. We've done a mix like the Gateshead data, with some going on for neoadjuvant chemotherapy, some going on to neoadjuvant endocrine therapy, and some going direct to surgery. And we've had no difference in our outcomes depending on whether, you know, they've had a long period with the scout in a short period, and even if the node has gone back to being anatomically normal, no problems with localization or excision. So out of our 17 scout-guided TADs, all 17 have had isotope for query allergy reasons. One patient did not have blue dye. 100% of the scouted nodes have been excised without issue. And then we've been obviously removing other hot and blue nodes afterwards. Our range of nodes excised was 3 to 6, with a mean nodes per procedure of 4.4. And we've had no loss of signal or scout failure, no intraoperative complications reported in the axilla, and the sole reported complication at follow-up is 1 axillary seroma out of 17. And I think everyone would agree that that would be in keeping with sentinel node complication rates, and we'd have expected a higher seroma infection rate with 17 axillary node clearances. Next slide. We've discovered that we have a mean macromet rate of 1.4 within obviously a mean excision of nodes of 4.4. So we on average tend to find that most patients have 1 or at most 2 pathological nodes. We have recommended completion axillary node clearance for 3 out of 24 patients who had more than 2 remaining macromets at their TAD. And out of the 24 patients that we recommended to have radiotherapy, 20 of those 24 have gone ahead and had axillary radiotherapy instead of an axillary node clearance. Next slide. So from our point of view, scout makes an effective marker both in the breast and the axilla, and it can be placed either at diagnosis or prior to neoadjuvant chemotherapy. It facilitates TAD without complication at insertion, and it's decoupled the need for localization on the day of surgery. It's definitely reduced the requirements on our radiology colleagues, and most of us feel in the breast it's decreased our surgical time, but certainly in the axilla I think everyone would agree that doing a targeted dissection is far quicker than doing an axillary node clearance. Thank you.
Yeah, thank you very much. Can I start by asking the first question, Matthew, if you don't mind? Have you had cases, among your series where maybe for some reason your radiologist did not mark the lymph node to start with, so before starting the neoadjuvant, but then, you've had to mark it, let's say, 1 or 2 cycles down the line?
So we have had the odd patient that has come back during neoadjuvant therapy recently, and the radiologists have commented that obviously, are we aware that we haven't put a scout in? Now, some of that is because I guess not every surgeon had automatically been comfortable with targeted axillary dissection, but they've gone back through MDT and we've then added it in mid-chemotherapy.
Yeah, so I was more trying to ask is that, so the radiologist was still able to locate it. And so there's an opportunity to, if you're not able to insert it at the very start, you're still able to insert it, let's say after 2 cycles.
Yes. We've actually on our MDT this morning had a patient, however, that had 1 pathological node at diagnosis. The surgeon did not organise axillary marking, and now post-neoadjuvant they obviously have a completely normal looking axilla. In that case, what we've just said to the patient is that they have to have a blue dye anisotope 4-dye sample or a clearance, and there's nothing that we can do. I think it's just about getting everyone, and there are now, because we've merged units, 13 of us, getting everyone used to requesting their localization before neoadjuvant chemotherapy. They've been very good at doing it in the breast, but they're just not quite so good at remembering to do it when it's 1 node positive in the axilla.
Thank you very much. I think on that note, I'll just remind everyone that in the ATNEC trial, although marking is recommended and we will provide resources and support, I think, but if you have this odd patient like Matthew talked about that for some reason the node was not marked, that patient will still be eligible for the study as long as you do a dual tracer sentinel node biopsy like the team did on this occasion. Any questions? That's fine. Can I ask by saying, I think, because I think a question was asked previously to our first speaker. So, from a size point of view, are you planning? I mean, I know Laura and other people are on the call. I mean, are you comfortable with the size that you offer at the moment, or do you have something in the pipeline which you're looking at regarding the size of the marker?
Well, if I'll go first and then I'll let Laura update you. We certainly haven't had any concerns about the size because the SAVI Scout is only a few millimeters. So it fits inside nearly any node. And certainly it fits either parallel to the odd 2 or 3 millimeter breast cancer we've detected or inside a cancer that's 5 millimeters or greater. So I don't think surgically we've got any desire or requirement for it to be smaller.
Thank you.
Just from an R&D point of view, yes, there is a smaller reflector being looked at. As previously mentioned by Mr. Milligan, that MDD is a bit backloaded at the moment, so testing for CE mark is a bit delayed, but FDA countries are currently have the use of a smaller reflector. which would be nice in the axilla for sure, understood. But as Mr. Rowland said, the actual reflector size itself is 5 millimeters. It's perceived to be bigger because the antenna make it look a bit longer, but the antenna is what gives it the grip for no migration. So that's a perception.
Thank you very much.
There's a question that just popped up. I think I can put that to all of the speakers. The question is, do you insert a hydromarker clip into the node at the time of the initial node biopsy in all cases?
Well, I'm happy to first. Our answer is no, because we would just put the SAVI scout straight in. We've therefore got no need for a hydrogel marker, because it is our marker as well as our localization.
Thanks, Matthew. Rob, do you want to comment on that?
Yeah, we spoke about this with our radiologist a couple of weeks ago. It came up in one of our MDTs, and no is the answer. Lots of them don't do it straight away, and they're all confident when they go back. If having taken a core biopsy from a LN3 node, they're confident that they can go back and find that node or a malignant appearing node at secondary ultrasound scan if it's proven positive to remark it for whatever surgery they need. So no, not all of them, but some of them do. It's a big cancer, young patient. You know, there's some patients, same with the breast tumours, again, for the neoadjuvant chemotherapy. Depends on the radiologist and the patient that you're dealing with, but lots will and some won't.
Yeah, thanks. Amit, do you want to comment on that too?
Yeah, I mean, we at Derby and Burton use a black dye, but I think the concept is the same. So whether if you're using a hydromark clip with or without any additional guidance, similar to us, so would you actually mark it at the time of biopsy or FNA or not? We discussed this and we evaluated this in the pre-ATNEC trial, which is published now. I'll just invite Beatrix, just to share. Her own center is a participant in ATNEC study. Maybe a couple of slides just to share her experience on node marking at her center. Beatrix, if you don't mind. Thank you.
Yeah, no problem. Thanks. As Amit and Sophie already said, I work up in Aberdeen, NHS Grampian, Scotland. We were one of the first sites to have site initiation visit in December 2020, but then it took a while to get RTTQA approval, and we only then opened in April 2021. So we've been open for about six months. Next slide, Sophie. Now, as any unit, I will start out with the ATNEC trial. There will be two pathways. Pathway where you can mark the axillary lymph node when you know that you have identified the patient in your MDT going for a neoadjuvant chemotherapy, and you can put a marker in the axillary lymph node. And then you have a pathway where the patients already have received neoadjuvant chemotherapy. They come for their postoperative neoadjuvant chemotherapy discussion to the MDT. You identify that the axillary lymph nodes have now normalized, and they can also go then into ATNEC. They can be registered and they can go for surgery. And I'm just going to talk through each pathway. Sophie? So over the first 6 months, we enrolled patient and registered patient in the post-neoadjuvant chemotherapy pathway. So they were identified in the MDT with having the normalized lymph node, but also we had a look back at the time of diagnosis. Our radiologist had to be able to tell us that they had less than 4 suspicious lymph nodes in the axilla. And only if they had less than 4 suspicious axillary lymph nodes, we considered them for going forward to have basically a sentinel lymph node with extra axillary lymph nodes being resected. So we wanted to have at least 3 axillary lymph nodes removed to be able to then go ahead and for the patient to be randomized. So when they come then postoperatively to the MDT, there was a few questions the pathologist needed to be able to answer. One, did we have all at least 3 lymph nodes in the axillary node sample? Was there any evidence that one of the lymph nodes had a core biopsy, which would have indicated that this was the lymph node which was involved and proven with regional spread? Was there evidence of any previous involvement, or with complete response, or was there any remaining disease left in the lymph nodes? And if all these conditions were fulfilled, only then the patient was randomized within ATNEC. Next slide. And if none of these ones, then they're just our oncologists were then going ahead and giving axillary radiotherapy. That's our default if we do axillary treatment in these patients. If any of these conditions were not fulfilled, there was no randomization. Next slide. So since we started ATNEC, we're trying to remember to then, when the patient goes for neoadjuvant chemotherapy, to put a hydromarker into, we use hydromarkers, into the lymph node. They get registered, they have the neoadjuvant chemotherapy, and they come for a targeted axillary dissection. We tend to, with the hydromarker X-ray, the lymph nodes we've taken out to ensure we have got the marker. We're currently trialing Magseed, so that's just a new technique we're trying to introduce. But again, the same thing happens in the MDT. The pathologist has to tell us that that there has been a response in the lymph node and there's no remaining disease left in the lymph node for the patient to go ahead and be randomized. That's all. I think there's no, that's just Aberdeen Royal Infirmary in sunshine, because at the moment we've got red travel warning with snow and high winds.
Thank you very much, Beatrix. The way I see it is, in the study is, so for sites, if they adopt targeted dissection, if you want to call that, or the sentinel node biopsy, post-neoadjuvant chemotherapy, in patients who are node positive to start with. So, and there is no residual cancer in the lymph glands. You could randomize patients, as Rob cite the data he presented, that most of the patients are going for radiotherapy if they had no residual cancer afterwards. So the way I see it working is that you could randomize patients between radiotherapy or no radiotherapy. So you don't necessarily have to randomize between clearance and no clearance. So the trial is very pragmatic. So depending on your site, you can choose whichever axillary treatment you prefer.